Hi everybody, this is Dr. Eric Lopez once again. I am going to be discussing the topic of endocrinology today. Again, all these topics are taken directly from my UWorld notes. I've tried to make them as concise as possible, and it's a good learning tool, especially if you're at the gym or on the road, like I've said before. It's a very passive way of just reviewing material. It is extensive. Usually these lectures are about 3 hours long, but they are as complete as I can get them. So let's jump ahead into the topic of endocrinology, and we're going to start with the thyroid gland. So let's start off with the topic of hyperthyroidism. First off, we're going to discuss an algorithm. So let's say you have signs of hyperthyroidism. What are you going to do next? The patient comes in and they have signs of hyperthyroidism. They have anxiety, sweating, tachycardia, and so forth. What do you do next? Well, you're going to want to draw labs and measure TSH and free T4. So you are either going to see TSH as low or high, or free T4 or low or high, and then now we're going to be going into detail with that. So let's say you measure the TSH, your free T4, and the TSH is low and the free T4 is high. That's basically your primary hyperthyroidism. And next up, you want to check out if they have signs of Graves' disease. If they do have signs of Graves' disease, then it's most likely Graves' disease. But if they don't, then you want to check a radioactive iodine uptake scan. The radioactive iodine uptake scan is either going to see if the thyroid took in that iodine or not. If it didn't, or if it's low, you want to go ahead and measure thyroglobulin. If the thyroglobulin is decreased, then that's usually due to an exogenous hormone, like somebody trying to lose weight and taking thyroid hormone to lose weight. But if your thyroglobulin is elevated, then that's either due to a thyroiditis or an iodine exposure or an extraglandular production of thyroid hormone. Think about thyroglobulin as something that elevates naturally when thyroid hormone is elevated. Now, if the radioactive iodine uptake scan is high, because remember, you have primary hyperthyroidism, but there wasn't any signs of Graves' disease, so you do the radioactive iodine uptake scan, and actually it is taking up a lot of iodine. So you want to find out, well, is it taking it up in a diffuse pattern or in a nodular pattern? If it's uptaking it diffusely, then that's Graves' disease. But if they are taking it up in a nodular pattern, then that's either due to a toxic adenoma or a multinodular goiter. And these two are going to occur due to activating mutations in those TSH receptors. All right, so what if you go back, all the way back to the algorithm, the patient had signs of hyperthyroidism, their TSH is low again, but here their free T4 is normal. However, they still have signs of hyperthyroidism, but their free T4 is normal. What do you want to do next? You want to measure free T3. If the free T3 is high, then that's probably due to a T3 toxicosis. And again, you want to check the signs of Graves' disease and do the algorithm there. If there is, then it's Graves' disease. If there isn't, you do the radioactive iodine uptake scan. If it's low, you measure thyroglobulin. If thyroglobulin is decreased, you want to check exogenous hormone. And if it's elevated, you're either thinking thyroiditis, iodine exposure, or extraglandular production. If the radioiodine uptake scan is high, then it's going to be either high due to a diffuse pattern, such as in Graves' disease, or a nodular pattern, such as a toxic adenoma, or a multinodular goiter. Okay. I'm going to be repeating these because it's very important. It's a long algorithm, and it's a good thing to just use as a memorization tool. All right, so what if you measured that free T3 because the T4 was normal? You went ahead and measured the T3, but the T3 now is normal. So you have normal T4, normal T3, low TSH. What is this? This is a subclinical hyperthyroidism. It could be early pregnancy, or it could be a non-thyroid illness. All right, moving along. Back to the beginning of the algorithm, you have signs of hyperthyroidism. You measure that TSH in the free T4. However, this time the TSH is either normal or high, and the free T4 is also high. What is this? This is secondary hyperthyroidism, and you'd want to check out an MRI of the pituitary gland, because at this point you're probably thinking of a pituitary adenoma that's just spitting out a bunch of thyroid hormone. Okay, so moving down, now we're going to talk about general manifestations of hyperthyroidism. So signs and symptoms would be anxiety and insomnia, palpitations, heat intolerance, increased perspiration, weight loss, without a decrease in appetite, and a goiter. And on physical examination, they're going to have hypertension, tremors involving the fingers and the hands. They could have hyperreflexia. They can have proximal muscle weakness, a lid lag, and atrial fibrillation. So those were your general manifestations of hyperthyroidism. If they present this with any of those symptoms, you want to do that algorithm that we just went over and measure TSH and free T4 first. Okay, now what are some of the effects of thyrotoxicosis due to on the cardiovascular system? So the rhythm of the cardiovascular effect is going to be sinus tachycardia. They can have premature atrial and ventricular complexes, as well as atrial fibrillation and flutter. Those are going to be the most important, the fibrillation and the flutter. Hemodynamic effects are going to be signs of systolic hypertension and increase in pulse pressures. So the systolic blood pressure is going to be highly elevated. There's going to be an increase in contractility and an increase in cardiac output, as well as a decrease in systemic vascular resistance and an increase in myocardial oxygen demand, because whenever there's an increase in contractility and cardiac output, the heart is working harder and it's going to require a lot of oxygen. Now, there's going to be an increase in sensitivity to catecholamines, and that mitral valve prolapse, mitral regurgitation, or tricuspid regurgitation are also going to be associated with thyrotoxicosis. Heart failure can also be a side effect of cardiovascular effect of thyrotoxicosis. There could either be a high output heart failure or an exacerbation of a pre-existing low output failure. And then they can also present with coronary vasospasm or pre-existing coronary atherosclerosis that can give you some signs and symptoms of angina. All right, so now what is the effects of the thyroid hormone or hyperthyroidism on bone disease? So excessive thyroid hormone is going to increase the activity of the osteoclast. The osteoclast is going to increase bone resorption. It's going to decrease the density of the bone, and it's going to increase the fracture risk. And because it's resorbing all that bone, osteoclasts are also going to cause hypercalcemia. And because there's high levels of calcium, the secretion of PTH is going to be decreased. So if there's decrease in PTH secretion, then the calcium reabsorption in the kidneys are going to be decreased. And since it's not reabsorbing that calcium, you're going to have hypercalciuria and net calcium wasting. And as well, if you have a decrease in PTH secretion, there's going to be a decreased conversion of 25-hydroxy vitamin D to the active form, which is 1,25-hydroxy vitamin D. There's going to be a decrease in conversion to that, and there's also going to be an increase in catabolism of the 1,25-hydroxy vitamin D, because your body already senses that it has enough calcium as it is. So it's going to break down the active form of vitamin D, and it's going to prevent that vitamin D to even be made, as well as it's going to decrease in the kidney the reabsorption of calcium, so you get hypercalciuria. Up to 60 to 80% of patients with untreated hyperthyroidism can develop myopathy. In acute thyrotoxic myopathy, that can present with more severe distal and proximal muscle weakness, but it's usually without bulbar or respiratory muscle involvement. Chronic thyrotoxic myopathy is usually proximal muscle weakness, and that happens weeks to months after the onset of hyperthyroidism. A thyrotoxicosis can cause hypercalcemia, and that's going to be due to the increase in bone resorption. Now, some of the objective findings would be that there could be a possible muscle atrophy. There could be high frequency or low amplitude tremors with movement. That's different than Parkinson's disease. And there can be normal to increased deep tendon reflexes with short relaxation times. So like spasming or tetany. And treatment of hyperthyroidism improves the myopathy. So once you treat that hyperthyroidism, the myopathy and all these hypercalcemia and everything will tend to die down because of the effects that thyroid has on the bones and the muscles. So diagnosis, how would you diagnose it? TSH will be low, free T4 will be high, that's hyperthyroidism, and you want to check a 24-hour thyroid radioactive iodine uptake scan to differentiate Graves from other causes. And then you also want to do an EKG to rule out any type of arrhythmia. So moving on, treatment. So propranolol is going to be the best initial treatment, and that causes symptomatic relief until the cause is going to be identified and definitively treated. It's going to relieve the tremors, tachycardia, it's going to relieve sweating and anxiety. And you want to start the dose very low at 10 milligrams orally, but remember, you don't have to worry about dosages on the exam. Just you start low and it becomes increased gradually until appropriate response is achieved, and it's usually 20 milligrams 4 times a day is needed. Okay, so other treatments would be radioactive iodine, and that's their definitive treatment. And there's clinical improvement is going to be achieved approximately 6 to 18 weeks. It's contraindicated though in pregnancy and in very severe ophthalmopathies. Young patients with cardiovascular disease do tolerate it well, but patients with cardiovascular disease do not tolerate temporary increases in thyroid hormone and are pre-treated with antithyroid drugs. So another type of treatment is subtotal thyroidectomies. That's going to be a definitive treatment. So if they ask you, what is the most definitive treatment in this patient? And they're going to give you a patient who's tried everything and there's just no way of helping them. Definitive treatment is subtotal thyroidectomy. And then propylthiouracil, 2/3 recur after 6 months, especially after stopping the medications, and it's usually given only when radioiodine is contraindicated, so in the case of pregnancy. And most common side effects of antithyroid drugs is going to be an allergic reaction. There can also be agranulocytosis, which usually develops within 90 days of treatment, fever and a sore throat. And then what you want to do is, if that happens, you want to stop the drug immediately. You want to check for white blood cell counts and start IV antibiotics, especially antibiotics that cover Pseudomonas. And if the total white blood cell count is less than 1,000, then you want to permanently discontinue propylthiouracil. And if it's more than 1,500, the drug is not going to be the cause of the fever or the sore throat. So because propylthiouracil is associated with agranulocytosis, you have to really check those labs and see about that white blood cell count. And if it's less than 1,000, permanently stop that drug. All right, next topic is the treatment of Graves' disease. So antithyroid drugs like thionamides, these antithyroid drugs can cause agranulocytosis, like we said. These are most serious, but they're rare, so you want to do routine white blood cell counts. Then you have methimazole, which is a first trimester teratogen, and it causes cholestasis. And then you have propylthiouracil, which causes hepatic failure and an ANCA-associated vasculitis. So just remember that about propylthiouracil. Radioactive iodine ablation would cause permanent hypothyroidism, and it can cause worsening of the ophthalmopathies, and it's a possible it could be a possible radiation side effects as well. So it's for radioiodine ablation, this is the preferred method in the US. So what is the most definitive is going to be radioactive iodine ablation. And the ophthalmopathy can be prevented by using high doses of corticosteroids before and after the treatment. Surgery causes permanent hypothyroidism. There's a risk of recurrent laryngeal nerve damage whenever you have surgery to the thyroid. That's a big one. And there's also risks of hypoparathyroidism as well, because of the parathyroids are in such close relationship to the thyroid. They're in the back of it. So there's chances of developing permanent hypothyroidism in radioiodine ablation. It's most common in patients with Graves' disease, as a whole thyroid gland is hyperfunctional. Although this complication can develop in any patient, patients with a toxic adenoma and a multinodular goiter are usually going to remain euthyroid after the procedure. All right, next topic is going to be thyroid storm. There's several clinical features of thyroid storm. Some of the precipitating factors would be like a thyroid or non-thyroid surgery, and also associated with acute illnesses like traumas or infections. Childbirth can also cause a thyroid storm, as well as acute iodine loads, such as iodine contrast agents. And basically, stressful situations can lead to a thyroid storm. They present with fevers as high as 40 to 41.1 Celsius, so 104 to 106 degree fevers. They get tachycardia, hypertension, congestive heart failure. There can be cardiac arrhythmias as well, such as atrial fibrillation, that being the most common. There's also signs of agitation, delirium, seizures, a coma, and also goiters with lid lag, tremors, warm and moist skin, nausea, vomiting, diarrhea, and jaundice. And how would you treat a thyroid storm? Well, first of all, you'd want to slow down any kind of things that are causing too much increases, like the tachycardia and stuff. So a beta blocker is a good one, so propranolol. So this decreases the adrenergic manifestations. Another treatment for thyroid storm would be propylthiouracil followed by iodine solution, and that's used to decrease hormone synthesis and to decrease the release of hormone. So iodine is given 1 hour after you give propylthiouracil. You do this to prevent the excess of incorporations of any type of iodine into the thyroid hormone. So that's propylthiouracil followed by iodine solution is another treatment for thyroid storm. Another treatment would be steroids, glucocorticoids like hydrocortisone. This is used to decrease peripheral conversion of T4 to T3 and improves vascular or vasomotor stability. And finally, another last treatment for thyroid storm is to identify whatever trigger is causing it and treat that trigger, as well as supportive care. So proposed mechanisms include a rapid increase in blood thyroid hormone levels. There's increased cellular responses to thyroid hormone and an exaggerated response to catecholamines. All right, next topic would be thyroiditis. So for thyroiditis, you have 3 different types of thyroiditis. You have Hashimoto's thyroiditis, a silent thyroiditis, which is a painless thyroiditis, and you have your classic subacute thyroiditis, which previously was all one word, subacute de Quervain's thyroiditis. So let's go in them each individually. So Hashimoto's thyroiditis, the predominant hypothyroid features are going to be the opposite of hyperthyroidism. So they'll have bradycardia, just slow things, diffuse goiters. And how do you test for Hashimoto's thyroiditis? So there would be positive thyroid peroxidase antibody test, or a TPO antibody. That's a typical clue for Hashimoto's, is an antibody to TPO, thyroid peroxidase antibody, as well as variable radioiodine uptake. But most importantly is that antibody to TPO for Hashimoto's thyroiditis. Now for silent thyroiditis, this is a painless thyroiditis, so they're not going to come in with any type of pain. They're just going to have swelling of their thyroid. They present with mild, brief hyperthyroid phases, and then a spontaneous recovery with small, non-tender goiter. And it's a variant of a Hashimoto's thyroiditis because it sounds similar. And these patients are also going to have positivity to TPO antibody, but here the difference is that they have a low radioiodine uptake versus in Hashimoto's, which also has a TPO antibody, but they have variable radioiodine uptake. Like some nodules are going to uptake the iodine, whereas in silent, none of them will be. Then you have your subacute thyroiditis or your subacute Devcourt veins thyroiditis. This is a painful one. This is the painful tender goiter that just touching it, just briefly, very superficially touching the skin is going to cause pain. So this is likely from a post-viral inflammatory process. So check in the vignette if they are recovering from a recent viral illness or inflammatory processes. Also, they'll have prominent fever and hyperthyroid symptoms, and again, that painful tender goiter with subacute thyroiditis. On diagnostic testing, they'll have elevated erythrocyte sedimentation rate and a positive C-reactive protein. And also, they have low radioiodine uptake. So this is the easiest one. This one is going to be painful. They're going to have a painful goiter, and they will be in the vignette that they are recently recovered from a viral illness. All right, so hypothyroidism. Hypothyroidism in the primary can be divided into primary, secondary. Primary is in the thyroid gland. It's primarily at the gland, is the way you remember it. So they'll have a low T3 with hypothyroidism, a low T3 and T4, and they'll have an increase in TSH with the TSH is going to be like more than 10. Versus secondary hypothyroidism, this is due to the hypofunctioning pituitary gland. So there'll also be a decrease in T3 and T4, and a decrease or inappropriately normal TSH. So here the TSH, the T3 to T4 is usually going to be low, versus in primary, TSH is going to be high. So that's how you distinguish them, because of the feedback mechanism. If there is feedback mechanism, then there's nothing wrong with the pituitary. This has to do with primarily the gland with primary hypothyroidism, whereas if the TSH is decreased as well as the T3 and T4, this is in the pituitary. There is lack of response to feedback. Okay, so rarely hypothyroidism features occur because of generalized resistance to thyroid hormone. There's anti-TPO and anti-Thyroidglobulin antibodies present in Hashimoto's thyroiditis, and in rare cases, there's anti-TSH antibodies that are present leading to small thyroid glands. The anti-TPO antibodies are going to be increased early on and then decreases with the course of the disease and with the course of the treatment. Clinical features of hypothyroidism are going to be your hyponatremia, hyperlipidemia, and they can be asymptomatic. There can be an increase in creatinine kinase, increase in transaminases like AST and ALT. There can be a normal chromic, normal cytic anemia due to a decrease in muscle mass, as well as pernicious anemia if there is chronic autoimmune thyroiditis. And that can lead to a macrocytosis, but without the megaloblastic anemia. There can also be iron deficiency anemia due to the menorrhagia. All right, so hyperlipidemia. So in the reason, let's talk about the reason of hyperlipidemia and hypothyroidism. So in hypothyroidism, there's a decrease in LDL surface receptors, and that's a type 2A hyperlipidemia. Or there could be a decrease in the LDL receptor activity, and this is going to cause an increase in cholesterol with an increase in LDLs. Also, this is also going to hyperlipidemia causes a decrease in lipoprotein lipase activity, and because there's that decrease in that enzyme lipoprotein lipase, the triglyceride levels are going to be increased. And if it's isolated, that's very rare, but there's an increase in triglyceride because of that lack of lipoprotein lipase with hypothyroidism. Lipid abnormalities correct slowly despite adequate hypothyroidism treatment, and statins are going to be given with caution due to an increased risk of myopathy in these patients. All right, let's talk about the hyponatremia with hypothyroidism. So there's decrease of clearance of free water, and that basically gives you the dilutional effect. So dilutional effect causes hyponatremia. Hypothyroidism and adrenal insufficiency should be ruled out before you ever diagnose SIADH. There's also an increase in norepinephrine, aldosterone, and systemic vascular resistance, and this can lead to an increase in blood pressure. So they can have an increase in blood pressure. So some of the major drug interactions of levothyroxine. So let's talk about levothyroxine. What does levothyroxine basically decrease the absorption of? So it basically decreases the absorption of bile acid binding agents like cholestyramine. Levothyroxine is also going to decrease the absorption of iron, decreases the absorption of calcium, and decreases the absorption of aluminum hydroxide. And it also decreases the absorption of proton pump inhibitors and decreases the absorption of sucralfate. Levothyroxine is also going to increase TBG concentration, or thyroid binding globulin concentration, because of that oral estrogen, tamoxifen, raloxifene, also heroin and methadone is going to be increased. Things that decrease thyroid binding globulin concentration would be like androgens, steroids, anabolic steroids, and slow release nicotinic acid. Also, an increase in thyroid hormone. Levothyroxine is also going to increase thyroid hormone metabolism. So drugs like rifampin, phenytoin, and carbamazepine, these basically are going to increase the activity of deiodinization, which is a major method, and glucuronidation and sulfation of enzymes in the liver. So thyroid binding globulin is synthesized in the liver, and oral estrogen, or basically the pregnancy state where you have increased levels of estrogen, are going to decrease the clearance of thyroid binding globulin. Now what's going to happen because of that, since there's a decrease in clearance of thyroid binding globulin levels are going to increase, binding that free T4, so free T4 levels are going to be decreased. And then during pregnancy, there's going to be, or stages where you have increased estrogen demand, there's going to be an increased dose of levothyroxine needed in order to counterbalance that thyroid binding globulin. Then transdermal estrogen bypasses the liver, and then the thyroid binding globulin isn't affected that way. So there can be a generalized resistance to thyroid hormone, and this occurs because of a peripheral tissue resistance to thyroid hormone, and that could be autosomal dominant. The disease classes can either be classified as either severe disease with resistance to thyroid hormone, or mild disease. So in severe disease, the patient's going to usually present early on in life, at early ages, with growth and mental retardations. And in milder diseases to resistance of thyroid hormone, that usually is going to present later on in life with signs of hypothyroidism and elevated T3 and T4 levels, which is normally going to be either normal or mildly increased levels of TSH. Okay, moving on, we have thyroid. Let's work up a thyroid nodule. So let's say you see a thyroid nodule. What are you going to do next is to clinically evaluate that nodule and get a TSH level. And you're also going to want to do an ultrasound. So in the vignette, if it says patient has a thyroid nodule, what do you do next? That's probably not going to be the question, but if it is, it's ultrasound or get a TSH level as well as clinically evaluate. But let's say you already did that in the vignette. what is the next thing you want to do? Well, you want to see if there is risks of cancer. If there is a risk of cancer on ultrasounds specifically, then you want to go to the next step as fine needle aspiration. But however, if there is no indications of risk factors for cancer, then on ultrasound, then you want to check the TSH levels. The TSH levels can be either low or normal. If you have a normal TSH, you still want to go ahead and do a fine needle aspiration, and treatment basically there is going to be based on whatever findings that you had for that fine needle aspiration. So whether or not you have cancer risks or without cancer risk suspicions, you still want to do a fine needle aspiration according to the TSH level. So, but if the TSH level is low, however, and you did not have any kind of cancer suspicions on ultrasound, then you want to check an iodine 123 scintigraphy. So iodine 123 will tell you if there's a hyperfunctioning nodule, or what they call a hot nodule, or they can have a hypofunctional nodule or a cold nodule. So if it's a hot nodule, you want to treat hyperthyroidism. If it's a cold nodule, you want to do FNA. So thyroid nodule evaluations is going to be based on those factors. Cancer risk factors are going to be like family history, cervical cancer history. There's radiation exposure in childhood. Also compression symptoms like hoarseness or difficulty swallowing. And the current thyroid status. Are they euthyroid? Are they hypothyroid? Are they hyperthyroid? And also on ultrasound findings, we were saying, what are some of the suspicions around a thyroid nodule on ultrasound? It could be either a hypoechoic nodule, or an internal vascularity within that nodule, or there can be microcalcifications. All those are red flags for suspicions of cancer. So what are the types of thyroid cancers? Thyroid malignancies, it could be either epithelial thyroid cancer, and that's a thyroid follicular cells, and that's the majority of the cases are 90 to 95% epithelial based, and that would be, the majority of the cases would be a papillary. More than 70% actually of epithelial thyroid malignancies are going to be papillary. And the risk factors here would be family history again, or childhood exposure to radiation. Those are the two big ones. There's also follicular cancer and anaplastic cancer, and these are all subcategories of epithelial thyroid malignancies, which are the majority: papillary, follicular, and anaplastic. Now, parafollicular C cells is another type of thyroid malignancy. This is a little bit more rare at 3 to 4%, and the type of thyroid malignancy that parafollicular C cells do is a medullary thyroid cancer. So parafollicular C cells for medullary thyroid cancer. And then you have your last classification, which is other, and that's less than 5% of the cases. And here you have your lymphoma, your sarcoma, your metastatic diseases like renal, breast, melanomas, or colon cancer. These can all cause thyroid malignancies. Now, next on is your parathyroid glands. So hyperparathyroidism is going to be our first topic here with the parathyroids. So this is an overview of primary hyperparathyroidism. So etiology for hyperparathyroidism is that you'll see 90% of the time a parathyroid adenoma. There can be hyperplasia at 6% of the time, or a carcinoma at the least amount of times at 1 to 2%, but most likely it's due to an adenoma. Symptoms, 80% of patients are going to be asymptomatic, and it's going to be identified via routine testing. Few patients are going to present with nonspecific symptoms like fatigue and weakness and mild depression. And there's also going to be abdominal pain. There could be renal stones, bone pain, fractures. There can also be the psychiatric manifestations that occur infrequently. That's your psychogenic overtones, bones, moans, and psychogenic overtones. So how do you diagnose primary hyperparathyroidism? So the diagnosis for primary hyperparathyroidism would be hypercalcemia with an elevated or inappropriately normal PTH, also a 24-hour urinary calcium that's in excess of 250 milligrams, as well as urine calcium creatinine concentrations that are that have a high differential pH from its normal, so more than 0.02, from a familial hypocalcuric hypercalcemia. Also, there will be bone mineral density testing to evaluate for osteopenia or osteoporosis because it's a known complication. And there's also three-dimensional system EB scans plus an ultrasound that locates the hyperactive parathyroid tissue prior to the surgery. And how would you treat primary hyperparathyroidism is with a parathyroidectomy for symptomatic patients or selected asymptomatic patients. So basically, in familial hypocalcuric hypercalcemia, this is basically 24-hour urine calcium, which is usually less than 100 milligrams. Surgery prevents the pH complications and is recommended for the following patients. So surgery is recommended if their serum calcium is more than 1 milligram per deciliter above the upper limit of normal, if they're younger than 50 years old, if they have a bone mineral or bone marrow density T-score of less than 2.5, or if they have a decrease in renal function with an estimated glomerular filtration rate of less than 60 milliliters per minute. Bisphosphonates can be used in those who refuse surgery and have prior histories of osteopenia and osteoporosis. Medical surveillance is used for older patients who have near normal calcium levels and no histories of osteopenia or osteoporosis. Now, patients with malignancy related to hypercalcemia, they have very severe hypercalcemia. They can have hypophosphatemia and a positive PTH related peptide. Okay, moving on. Now we're going to do the algorithm for secondary hyperparathyroidism. So in secondary hyperparathyroidism, you're going to present with chronic kidney disease. So their GFR is going to be low right off the bat. So then you're going to have to check for levels of 125 hydroxyvitamin D and if there's any type of phosphate retention. So if you have low levels of 125 hydroxyvitamin D, then that'll cause a decrease in intestinal calcium absorption. The decrease in intestinal calcium absorption is then going to lead to low serum calcium, and that low serum calcium is basically going to cause an increase in PTH synthesis, causing secondary hyperparathyroidism. Another way that the chronic kidney disease can cause secondary hyperparathyroidism is through phosphate retention. So the phosphate retention is going to cause high levels of phosphate in the serum, which is going to basically cause a counter effect with calcium, so you'll have low calcium levels in the serum, and again that'll trigger PTH synthesis to increase, causing you to have secondary hyperparathyroidism. Now, the magnitude of the rise in the PTH is going to be directly correlated with the severity of the renal failure. So the worse the renal failure, the higher the PTH release. All right, hypoparathyroidism is our next topic. So in hypoparathyroidism, you have primary hypoparathyroidism, which is hypocalcemia with a hyperphosphatemia and normal renal function tests. And what are the causes of this? Post-surgical is going to be the most common, like let's say in a thyroidectomy or a subtotal parathyroidectomy, which is when they remove about three and a half of your parathyroid glands for parathyroid hyperplasia, and that basically is causes severe symptoms even when there's mild hypocalcemia. Then you have autoimmune causes of hypoparathyroidism, and that's the most common non-surgical cause. So the most common is surgical, the most common non-surgical is autoimmune causes of hypoparathyroidism. Congenital absence or maldevelopment of the parathyroid gland, like in DeGeorge syndrome, that's another cause. Also defective calcium sensing receptors on the parathyroid glands themselves. and a non-autoimmune destruction of the parathyroid gland due to like infiltrative diseases such as hemochromatosis or Wilson's and neck irradiation. So clinical features, they could be basically asymptomatic at first, but then they can be found that can lead to an incidental finding, or they can complain of only non-specific symptoms like fatigue, anxiety, depression, and there could be perioral tingling or numbness. There could be muscle cramps, tetany, carpal pedal spasms, seizures in severe cases, and there can also be a prolongation of the QT interval. That's a big one right there. Prolonged QT interval for hypoparathyroidism. So how is calcium metabolized? All right, and basically this is kind of like an algorithm, but basically PTH releases from the parathyroid glands, and it goes where? It goes to the bones and it goes to the kidneys, and the bones is going to increase the resorption of bone and the formation of calcium and a release of calcium. So this is going to lead to an increase in circulating calcium levels. Because now you have high calcium levels, this is going to negatively inhibit the PTH release, and that's how it goes. Also, PTH releases from the parathyroid glands, and it could go not only to the bones, it goes to the kidneys. And in the kidneys, it can either go two ways. In the kidneys, you can have direct increase in calcium reabsorption, leading to hypercalcemia, or you can have the formation of vitamin D through the 125 hydroxy vitamin D formation, which is the active form. And that causes an increase in GI calcium and phosphorus absorption, also leading to high circulating calcium, which then negatively inhibits the release of PTH from the parathyroid glands. So how do you diagnose hypercalcemia? So you want to confirm hypercalcemia by repeat testing, and then you want to correct for albumin concentration and measure the ionized calcium, because ionized calcium is the one that you need to measure. Then you want to measure PTH levels. So high to normal or elevated PTH levels would be a PTH dependent hypercalcemia, whereas if you have low PTH levels, this would be a PTH independent hypercalcemia. If it's PTH independent hypercalcemia, then you want to also measure parathyroid hormone related peptide, or PTHrP. You want to measure 25 hydroxy vitamin D levels as well as 125 dihydroxy vitamin D levels. So what are the causes of either PTH dependent or PTH independent hypercalcemia? For PTH dependent hypercalcemia, meaning that you need PTH levels to be high as well as calcium levels to be high, the causes here are primary or tertiary hyperparathyroidism, and it can also be lithium intoxication or familial hypercalcemic hypocalciuria. So a lot of calcium retention. You have hypercalcemia, high calcium in the bloodstream, hypocalciuria, not enough calcium in your urine. Now that's PTH dependent. PTH independent hypercalcemia causes, number one is malignancy, followed by vitamin D toxicities, granulomatous diseases, because those cause hypercalcemia, drug-induced hypercalcemia like thiazides can do it, milk alkali syndrome, thyrotoxicosis, vitamin A toxicity, and immobilization can all lead to a PTH independent hypercalcemia. So what are the vitamin D induced hypercalcemias? So causes of vitamin D induced hypercalcemia could be either endogenous causes or exogenous causes. For the exogenous causes would be non-prescription medications or non-prescription things like supplemental megadoses of vitamin D or vitamin D fortified foods. But if there is prescription medications, there would be like calcidiol, which is 25 hydroxy vitamin D, calcitriol, which is the 125 hydroxy vitamin D, calcipotriene, which is a topical vitamin D derivative, and then you have your vitamin D2 or vitamin D3. Those are all exogenous, meaning that you have to ingest the vitamin D or somehow put it into your body. Endogenous causes would be causes like granulomatous diseases like sarcoidosis, as well as lymphomas can cause a vitamin D hypercalcemia. Then you have malignancy-associated hypercalcemia, and causes here would be PTH related peptide production or PTHrP production. 80% of the malignancy-induced hypercalcemias are going to have the PTHrP production, the related peptide. And tumors that are associated with this would be squamous cell cancers like the lung, the head, the neck, and the esophagus. Those are squamous cell cancers of those areas, can give you PTHrP levels that are increased. Renal and bladder cancers, ovarian and endometrial cancers, as well as breast cancer. And the mechanism behind this is that the activation of the PTH receptor can cause excessive bone resorption. Now, another cause of a malignancy-associated hypercalcemia would be the production or overproduction of 1,25-dihydroxyvitamin D. And the tumor that is mostly associated with that would be all types of lymphomas. The mechanism behind that would be that there would be excessive gut absorption of calcium. Other causes of malignancy-associated hypercalcemia would be bone metastasis. So breast cancer is number one, followed by multiple myeloma, and lymphomas can all be metastatic cancers that cause hypercalcemia. And the mechanism here would be release of local factors such as cytokines or stimulation of bone resorption itself. And then finally, ectopic PTH production, which is very rare. Tumors are variable in these cases, and the mechanism here is just straight bone resorption. So humoral hypercalcemia of malignancy will basically be an increase in parathyroid hormone related peptide, and that's going to cause an increase in bone resorption. And it's also going to cause an increase in absorption from the distal convoluted tubule in the kidney, leading to high levels of calcium. It does not induce the conversion of 25 to 125-dihydroxyvitamin D to the same extent that PTH has it, and hence its levels are going to be either low or low normal. Then you have severe hypercalcemia associated with humoral hypercalcemia of malignancy, and this is a hypercalcemia that's more than 14. So remember that number, more than 14 is malignant hypercalcemia, as compared to mild or moderate hypercalcemia, which is going to be levels that are less than 14. So like in primary hyperparathyroidism and in mild hypercalcemia, you'll have less than 12 grams per deciliter of calcium, as well as in thiazide uses. So when it comes to malignancy, the levels of calcium are going to be through the roof versus normal hypercalcemic states such as hyperparathyroidism, and medication uses like thiazide will give you high levels of calcium but not excess of 14. And it's usually seen in advanced malignancies, and since it's in advanced malignancies, it's going to lead to a poor prognosis. So the phosphorus level is usually going to be normal in lytic bone metastasis, and it's also a rare condition as compared to the humoral hypercalcemia of malignancy. And then you can also get hypercalcemia if you're immobilized. So hypercalcemia of immobilization is an unclear mechanism, but it's likely due to the increase in osteoclastic bone resorption. There's an increased risk in patients with an increased pre-existing bone turnover, like younger individuals or older people with Paget's disease. And there's an onset of hypercalcemia, which depends on the bone turnover and calcium excretion by the kidney. There's a median time of 4 weeks after the onset of immobilization, and patients with chronic renal failure are going to basically develop hypercalcemia early on, as early as 3 days of immobilization because the kidneys aren't working. So prolonged immobilization is going to lead to a significant bone loss, and you want to prevent this by giving them bisphosphonates. And then you can treat them by hydrating them and giving them bisphosphonates. As simple as that. It's a nice way of prevention. Now, hypocalcemia, the cytochrome P450 inducers can cause conversions of vitamin D into inactive metabolites. So renal failure and rhabdomyolysis and phosphate administration can all lead to precipitation of calcium with phosphate, and that can lead to a hypocalcemia, as well as certain drugs like phenytoin, bisphosphonates, calcium chelators, and rhabdomyolysis. So rhabdomyolysis initially causes a hypocalcemia, and that's due to the precipitation of calcium and phosphorus release from damaged muscles. Later, they develop hypercalcemia during diuretics or recovery phases of illnesses, and 40% of calcium is bound to proteins, mainly to albumin. So if it's bound to albumin in hypoalbuminemia, that can actually decrease total calcium levels and not ionized calcium levels. So the serum calcium concentration is going to be decreased by 0.8 milligrams per deciliter for every 1 gram of deciliter decrease in serum albumin, and that's expressed in this formula for corrected calcium, which is the measured total calcium plus 0.8 times 4 minus the serum albumin. I really doubt that you're going to have to memorize something like that for that exam, but you never know. So what are some of the diagnostic approaches of hypocalcemia? So low corrected serum calcium levels are confirmed via a repeat testing. So ionized serum calcium in some cases. So then you ask yourself, the low magnesium levels, is it due to a drug? Is it due to a recent blood transfusion causing an increase in citrate volume? If the answer is yes, then you want to correct the cause. If the answer is no to the low magnesium or the drugs, then you just want to measure PTH level. PTH level can either be normal or low, or it can be elevated. So if you get high levels of PTH, so potential causes can be either due to endocrine causes like vitamin D deficiency or chronic kidney disease. It can be due to inflammatory processes like pancreatitis and sepsis. And it could be caused by oncology causes like tumor lysis syndrome. If there is low to normal PTHs, then potential causes would be either surgically, like parathyroidectomies, thyroidectomies, and radical neck surgeries, as well as autoimmune causes like polyglandular autoimmune syndromes, and infiltrative diseases like metastatic cancer, Wilson's disease, and hemochromatosis can all cause hypocalcemia with a low PTH. So what if the hypocalcemia is acute? What are some of the causes of acute hypocalcemia? Number one is going to be neck surgery due to, let's say, a parathyroidectomy. Also pancreatitis, because hypocalcemia occurs in acute pancreatitis and not in chronic pancreatitis. Sepsis as well. There's tumor lysis syndrome, like we said earlier, acute alkalosis, and then chelation is the other one. Chelation, like blood, the citrate in the blood, when you do a blood transfusion, that can cause it, and as well as EDTA or Foscarnet. So chelation and neck surgery are basically the most common causes, or the most high yield causes of acute hypocalcemia. Clinical features of acute hypocalcemia would be muscle cramps, the Schaff-Stick, and Trisal signs. There's they have paresthesias, hyperreflexia, tetany, and seizures, plus laryngospasms. They can have encephalopathy and heart failure as well. And how would you treat acute hypocalcemia? You'd want to treat it with IV calcium gluconate or chloride. So hypocalcemia is actually uncommon after a blood transfusion in patients with normal liver. But in patients with a decrease in liver function, then that causes they're prone to have hypocalcemia because of the decreased ability of the liver to remove the citrate rapidly. Citrate, again, is found in blood products that can chelate the calcium. But if your liver is actually making citrate, then there shouldn't be, or not making it, but is able to remove it, then there shouldn't be a problem. Versus people who have liver disease, they can't really remove that citrate, so hypocalcemia happens. Hypomagnesemia can present similarly to hypocalcemia, but in hypomagnesemia, there's a PTH resistance. Then that leads to a decrease in PTH secretion. Low PTH is going to lead to hypocalcemia and normal or low levels. There's also decrease in GI absorption and an increase in urinary loss of phosphorus in alcoholics. And it's common in alcoholics due to increase in urinary loss, malnutrition, acute pancreatitis, as well as diarrhea. And basically they don't respond to calcium. Magnesium repletion is going to cause quick PTH recovery, and then calcium is going to take time to reach its normal level, but the PTH will recover once you replete magnesium levels. Severe hypermagnesemia will lead to hyporeflexia, apnea, paralysis, and cardiac arrest. And if there's very severe hypermagnesemia, that can actually inhibit PTH and lead to hypocalcemia. And that typically occurs after infusion of magnesium in a preeclampsia or eclamptic state. Remember, magnesium is given to preeclampsia patients to prevent seizures. Now, the effects of acidosis and alkalosis on ionized calcium levels. So basically, when you have acidosis, you're going to have an increase in ionized calcium, versus when you have alkalosis, you're going to have low ionized calcium. And the reason there is because in acidosis, you have more hydrogen ions bound to albumin than you do calcium. But in alkalosis, you have less hydrogen ions bound to albumin, and then you have more calcium bound to albumin. So you have a decrease in ionized calcium. So high ionized calcium if there's acidosis, low ionized calcium if there's alkalosis. All right. Moving on, for osteomalacia, clinical features of osteomalacia causes will be malabsorption, intestinal bypass surgeries, celiac sprue, chronic liver disease, chronic kidney disease. Those all are causes of osteomalacia. And some of the symptoms and signs could be either bone pain or muscle weakness, muscle cramps. There can be difficulty in walking, so they can have a waddling gait. But it can be asymptomatic. Keep that in mind. But the diagnosis here, there's going to be at high levels of ALP-Phos. There's going to be increase in PTH and low calcium, serum calcium, and low phosphorus. There's also going to be a decrease in urinary calcium, and there's going to be low 25-hydroxy vitamin D levels. On X-ray, they can show thinning of the cortex with reduced bone density, and eventually they'll have a codfish vertebral bodies, which are concave-shaped vertebral bodies from that. So then you have bilateral and symmetric pseudofractures, which are basically loose zones or characteristic findings on X-ray. Osteomalacia is due to a defective mineralization of the osteoid bone matrix, and it can occur in children and in adults. Rickets in children is a defective mineralization of the actual growth plate. Causes is, most commonly, it's due to vitamin D deficiency, and it's also caused by renal tubular acidosis type 2, as well as inadequate calcium intake. Vitamin D deficiency leads to low calcium and low phos, and that basically stimulates PTH to increase, so you'll have a high PTH, which leads to then high calcium reabsorption from the bone and an increase in alkaline phosphatase. Whenever you have bone resorption, you'll have an increase in alk phos. And in the kidneys, there can be an increase in phosphorus loss from the kidneys, and that leads to more severe phosphate deficiency than calcium deficiency, especially in the early stages of the disease. Clinical features would be fractures, especially fractures in weight-bearing joints in the lower extremities. All right, moving on. So Paget's disease. In Paget's disease, there could be a normal serum calcium, a normal phosphorus, and a normal parathyroid hormone. It's the marker of bone resorption would be like your C-telopeptide and the N-telopeptide. And for bone formation, always remember alkaline phosphatase and osteocalcin, which is going to be significantly increased with Paget's disease because there's a lot of bone resorption. So we're going to talk next about the adrenal gland. So let's talk about Cushing's syndrome. So in Cushing's syndrome, what do you want to do first? You want to do a 24-hour free urine cortisol. If there's an increase in 24-hour urine-free cortisol, then that's basically Cushing's syndrome. So what do you want to do next? You got the Cushing syndrome. You want to check ACTH levels. ACTH levels can be low or high. If they're low, like less than 5 milligrams, then you want to do an adrenal CT scan. Never start an endocrine with a scan of any sort, with any type of imaging. That's a number one rule. Anything endocrinology, you never start with a scan because it can give you false positives. So after you've checked the ACTH levels and they come out as being low, then you do an adrenal CT scan. Why? Possible causes could be exogenous glucocorticoids. It could be an adrenal adenoma, or it can be a primary pigmented nodular adrenocortical hyperplasia. But when you check the ACTH levels and they're normal or high ACTH levels can either be caused by Cushing's disease, it could be due to an ectopic ACTH production, or it could be caused by ectopic CRH production. So you have your high or normal ACTH levels. What do you do next? You do a pituitary MRI. In the pituitary MRI, you basically check to see if there's masses. If there are no masses, or if there's a mass that's less than 6 millimeters, then you want to do something called inferior petrosal sinus sampling. At this stage, once you do that, you want to do a central step up to find out if it's either ectopic ACTH secretion or if it's Cushing's disease. If there's a step up, it is Cushing's disease. If there isn't, then it's an ectopic ACTH secretion. So what are some of the ACTH secretion symptoms? They'll have rapid onset of hypertension, metabolic alkalosis, hyperglycemia, and proximal muscle weakness from the hypokalemia, as well as absence of typical Cushing syndrome symptoms. However, if you do a pituitary MRI and it's more than 6 millimeters, then you want to do a dexamethasone suppression test and the CRH test. If there's suppression of cortisol and there's still elevation of ACTH, then that's Cushing's disease as well. Okay, so features of Cushing syndrome. Some clinical manifestations would be progressive central obesity, like fat accumulations in the cheeks and in the dorsocervical and supraclavicular fat pads. There can also be skin atrophy and wide purpurish striae. Also proximal muscle weakness, hypertension, glucose intolerance. There could be skin hyperpigmentation due to the ACTH excess. And how would you diagnose is with a 24-hour urinary cortisol excretion. You can also diagnose for Cushing syndrome as late evening salivary cortisols or a low-dose dexamethasone suppression test. So ectopic ACTH production is going to be the most common with lung cancer, specifically small cell lung cancer. that has a rapid onset of symptoms, as well as carcinoid syndrome, like bronchial carcinoid, pancreas, and the thymus has a slow onset of symptoms. So what about adrenal insufficiency? So if there's signs and symptoms of adrenal insufficiency, you want to go ahead and do a 250 microgram concentropin stimulation test with cortisol and ACTH levels. So the cortisol levels should be a basal early morning cortisol. So if the cortisol levels are intermediate, then further testing is needed to assess any type of pituitary function. If the basal cortisol levels is low and ACTH is high, then you want to do and also if there's minimal cortisol response to concentropin, that's a primary adrenal insufficiency. If the basal cortisol levels is low and the ACTH is also low, and there's minimal or suboptimal cortisol responses to concentropin, then a secondary or tertiary adrenal insufficiency is the cause. And if there is a normal response, like cortisol levels of more than 20 micrograms per deciliter, or 36 minutes after a concentropin test it's still normal, then it's unlikely to be an adrenal insufficiency, and you want to investigate other causes. So primary versus central adrenal insufficiency. In primary adrenal insufficiency, the most common cause is going to be autoimmune causes. There's going to be low cortisol and high ACTH levels. Aldosterone levels are going to be low, and their clinical features are going to have severe symptoms, hyperpigmentation. They can have a hyperkalemia, hyponatremia, and hypotension. And in secondary adrenal insufficiency, the most common cause would be a chronic glucocorticoid therapy. Again, you'll have low levels of cortisol, but the ACTH in secondary adrenal insufficiency is going to be low, and aldosterone is going to be normal. Features here are going to be less severe features. There's not going to be any hyperpigmentation, there's no hyperkalemia, and there are possible signs of hyponatremia. The hyponatremia is because there's an increase in antidiuretic hormone secretion, so you get the dilutional effect. So a quick little recap on the HPO axis. You have your hypothalamus, and then you have your paraventricular nucleus. This is going to basically stimulate the anterior pituitary through the portal vein, and there's in the anterior pituitary you have your corticotroph cells, which are going to release ACTH into the adrenal gland. It's going to stimulate the adrenal gland to release cortisol. Cortisol is going to then just be released, and it's going to inhibit negatively on the release of ACTH, because it's going to say we don't need any more stimulation to produce cortisol. And it's also going to go ahead to the paraventricular nucleus and also inhibit the release of CRH and ABP release. So clinical features of primary adrenal insufficiency or Addison's disease is that they're going to have a normal anion gap metabolic acidosis, low cortisol, and aldosterone and sex steroids. So what are some of the clinical features of primary adrenal insufficiency? So the etiologies of primary adrenal insufficiency is that, number one, it's autoimmune. Infections can also cause it, like TB, HIV, disseminated fungal infections can do it. Diseases like coccidiomycosis, histoplasmosis, and cryptococcus, as well as sarcoidosis, can also cause primary adrenal insufficiency. Hemorrhagic infections like a meningococemia and anticoagulants, and metastatic cancers like metastatic lung cancer are all causes of primary adrenal insufficiency. And how do they present? Well, acutely, is most commonly with shock. That's how they present, with shock if it's acute. Also abdominal tenderness with deep palpation, but that's an unclear etiology. Also unexplained fever, nausea, vomiting, weight loss, anorexia, altered mental status, There could be hyponatremia, hyperkalemia, hypercalcemia, and eosinophilia. But chronically, how do they present? With fatigue, weakness, and anorexia. There could be GI symptoms like nausea, vomiting, and abdominal pain. There could be weight loss, hyperpigmentation, or vitiligo. There's salt cravings chronically. There's hypopigmentation, hyperkalemia, hyponatremia, hypercalcemia, so that's the same as acute symptoms, and then anemia and eosinophilia. And how would you diagnose? Primary adrenal insufficiency is first you measure ACTH and serum cortisol with a high dose ACTH stimulation test. Primary adrenal insufficiency will give you a low cortisol and high ACTH, versus secondary or tertiary adrenal insufficiency also gives you low cortisol but a low ACTH. So secondary adrenal insufficiency, the HPA axis is not suppressed if steroids are taken for less than 3 weeks or in doses of less than 5 milligrams, so you don't need to do a stress dose. Intermediate doses of steroids like 5 to 20 milligrams or equivalent can lead to an evaluation with early morning cortisol levels before surgery to do a stress dose. The HPA axis is also suppressed if prednisone is taken daily or if it's taken for more than 3 weeks in high doses. And those with cushingoid features are also at increased risk of the HPA axis suppression, and that's needed at higher dosages for short-term steroids in acute conditions, and that's your stress dose. Then a normal HPA function is not fully recoverable until 6 to 12 months after the discontinuation of the medications. There's a drug called etomidate, which can inhibit steroid synthesis and inhibition, and it's an acute adrenal crisis, so it can inhibit an acute adrenal crisis. So you want to avoid in patients that have suspected HPA suppression. And then clinical features of secondary adrenal insufficiency again would be hyponatremia, hyperkalemia, hypoglycemia, and hypotension, needing large amounts of IV fluids. Acute adrenal insufficiency or adrenal crisis, the risk factors here would be an adrenal hemorrhage or infarction, also acute illnesses, injury or surgery in patients with chronic adrenal insufficiency, chronic steroid use, and congenital adrenal hyperplasia can lead to an acute adrenal insufficiency or adrenal crisis. Clinical features of an adrenal crisis would be hypotension and shock, that's number one. Nausea, vomiting, abdominal pain, there's weakness, there could be fever, and an acute kidney injury as well. Diagnostic testing revolves around cortisol levels, electrolytes, BUN, creatinine, glucose, ACTH levels, renin, and ACTH stimulation tests when they're stable. And treatment for an adrenal crisis would be hydrocortisone or dexamethasone, and high-flow IV fluids. So IV fluids is a big one. The hydrocortisone is another big one. And monitor the serum electrolytes. Screening, all of the above 3 tests mentioned, a basal early morning cortisol levels, ACTH, and clostropin levels, which is a synthetic ACTH analog, are all performed simultaneously to expedite the diagnosis as a result for ACTH that can be taken several days. Low cortisol, so less than 5 micrograms, and high ACTH, remember that's primary adrenal insufficiency, also known as Addison's disease, but if you have low cortisol and low ACTH, that's a central adrenal insufficiency or a pituitary hypothalamic cause of adrenal insufficiency. The early morning cortisol is going to be 5 to 15 micrograms, and that's going to be intermediate, versus early morning cortisol that's more than 15 micrograms. It's going to be a very low risk of adrenal insufficiency. And then you have your 24-hour urine cortisol that is not recommended for that. Treatment would be hydrocortisone, and that started as soon as the diagnosis is established, and you may not want to wait for those test results to come in. You just want to start hydrocortisone in an acute condition. There could be insulin tolerance tests, also called the insulin hypoglycemia test, and that's a difficult test and it's not commonly performed, so hence it's not commonly tested. Insulin is basically going to lead to hypoglycemia, which activates the hypothalamic pituitary adrenal axis in normal individuals, and that leads to a normal response. But if it's abnormal, the response is blunted in patients with primary or central adrenal insufficiency. So the next topic here would be congenital adrenal hyperplasia. So this is going to depend on the enzyme that's deficient. So you either have 21-hydroxylase, 17-hydroxylase, or 11-hydroxylase deficiency. So let's go through them. Let's start off with 21-hydroxylase deficiency since it's the most common. It's most commonly due to a 21-hydroxylase deficiency in 90% of the cases. The 21-hydroxylase deficiency is going to have a decrease in cortisol, and there's going to be a decrease in aldosterone as well. However, there's also going to be an increase in testosterone. There's also going to be an increase in the 17-hydroxyprogesterone. Symptoms here with 21-hydroxylase deficiency would be ambiguous genitalia in girls, salt wasting or vomiting, and hypotension, as well as hyponatremia and hyperkalemia. So that would be your salt wasting. For 11-beta hydroxylase deficiency, there's also a decrease in cortisol and aldosterone. So all of these enzyme deficiencies are going to give you a decrease in cortisol and aldosterone. And in 11-beta, you also have a high testosterone levels. And here you have an increase in 11-deoxycorticosteroid. Now, here's the difference between 21 and 11 is that in 11-hydroxylase deficiency, the increase in 11-deoxycorticosterone, that's a weak mineral corticoid. So they're going to have hypertension. They're going to have fluid and salt retention, and they're going to have also ambiguous genitalia in girls. So the difference between both of them is that one of them is going to present with hypertension versus the other one that won't. So 21-hydroxylase will not present with hypertension. They'll actually present with hypotension, versus 11 is going to present with hypertension. And then finally, 17-alpha hydroxylase deficiency, again, low cortisol and low testosterone, but they're going to have increase in mineralocorticoids and an increase in corticosteroid, which is a weak glucocorticoid. With 17-alpha hydroxylase deficiency, all patients are basically phenotypically female. Even the male chromosome ones are going to phenotypically be female. And again, they're going to present with hypertension since mineralocorticoids are increased, and they're going to have fluid and salt retention. So then a marked increase in 17-hydroxyprogesterone is diverted towards adrenal androgen synthesis, and that leads to a hyperandrogenism, which causes impairment of the hypothalamic sensitivity to progesterone. And because of that, that's going to increase GnRH synthesis rapidly, causing an increase in LH and FSH, which is then going to increase steroid production. So that's why you'll have increase in 17-hydroxyprogesterone, an increase in DHEA, increase in testosterone, and in LH and FSH. And then what you should check would be an ACTH stimulation test, which will show an exaggerated 17-hydroxyprogesterone response. Then because of that, the cosentropin stimulation test is the gold standard for partial deficiencies. So a decrease in cortisol is going to lead to an increase in ACTH, and that's adrenal hyperplasia. And a decrease in aldosterone is basically salt wasting. So the clinical features depend on the degree of the enzyme deficiency. So for instance, in a severe classic 21-hydroxylase deficiency, the patients present in infancy with virilization and salt losing crisis. And then late onset with non-classical 21-hydroxylase deficiency would be found in females, and it's a mild disease. And it's present in the teens or in their 20s with and they'll present with cystic acne that's not responsive to medications. So that would be a clue on the vignette. A teenage girl who has cystic acne that's not responsive to medications with irregular menses, as well as hirsutism and virilization. So be careful with Turner syndrome or PCOS, because it does look similar. And boys are going to, if it's in a boy, it would present with precocious puberty, and hyponatremia is going to be variable in both sexes. But the non-classic 21-hydroxylase deficiency, the late onset one, is a CYP21A2 deficiency. Apparently that is testable. CYP21A2. Okay, then moving on, you have your adrenocortical cancers, which are rare and aggressive, and they present in adulthood usually, and there's different types. There's androblastoma, there's arenoblastoma, there's a stromal and the Hylas cell tumor, and clinical features of these cancers would be rapidly progressive hirsutism with virilization sometimes. So that could be, if you see in the vignette, a rapid progression of hirsutism. So they weren't hairy before, but suddenly now they are. You can look for adrenocortical cancer. And on labs, the serum DHEAS, which is your adrenal androgens, are going to be markedly increased of more than 700 micrograms. All right, so moving on, we have hyperaldosteronism, and we have different causes of hyperaldosteronism. So let's break it down. So they'll present basically with hypertension and hypokalemia. So if a patient presents with hypertension and hypokalemia, you got to check the renin and the aldosterone. 3 scenarios here. If both renin and aldosterone are going to be increased with hypertension and hypokalemia, that's secondary hyperaldosteronism. This is a renovascular hypertension or a malignant hypertension, or it could be a renin-secreting tumor, or it could be due to diuretic use. Primary hyperaldosteronism is going to present with a patient that has hypertension, hypokalemia, but they'll have low renin and high aldosterone. That's primary hyperaldosteronism, and that would be an aldosterone-producing tumor, or it could be bilateral adrenal hyperplasia. So whenever you see hypertension, normally the renin would be high, but if they have hypertension with low renin, this is probably going to be one of those two: primary hyperaldosteronism with an aldosterone-producing tumor, or bilateral adrenal hyperplasia. But let's say the patient has hypertension and hypokalemia, but both the renin and the aldosterone are decreased. Well, these are non-aldosterone causes. So examples of these would be congenital adrenal hyperplasia, deoxycorticosterone production by an adrenal tumor. It could be Cushing's syndrome, or it could be exogenous mineralocorticoid use. All right, so let's say you have a suspected hyperaldosteronism, and you have hypertension with hypokalemia, because that's always the case. Hypertension with low potassium, you're thinking hyperaldosteronism. So what is it that you do next? Measure the plasma renin activity and the plasma aldosterone concentration. So again, if you have an increase in renin aldosterone and an increase in aldosterone concentration, this is secondary hyperaldosteronism, and it's either due to diuretic use, it could be due to cirrhosis or congestive heart failure, it could be renovascular hypertension, it could also be a renin-secreting tumor, a malignant hypertension, or coarctation of the aorta can also do it. If you have a low renin, high aldosterone, that's your primary hyperaldosteronism with it's either due to an adrenal source. So you want to check out an adrenal CT scan to determine the etiology there after you get those levels of renin and aldosterone. But if your renin and aldosterone are both decreased, these are other causes of hypertension and hypokalemia. Look for congenital adrenal hyperplasia, steroid resistance, exogenous mineralocorticoid use, Cushing syndrome, or altered aldosterone metabolism. Okay. So in primary hyperaldosteronism, what are the clinical features of primary hyperaldosteronism? So clinically in hyperaldosteronism, they present with hypertension, they can present with metabolic alkalosis, with hypokalemia, and mild hypernatremia. There's no significant peripheral edema due to an aldosterone escape. And how do you diagnose it? With elevated plasma aldosterone levels, as well as low plasma renin. The plasma aldosterone to plasma renin ratio is more than 20 is going to suggest a diagnosis of primary hyperaldosteronism. An adrenal suppression testing after oral saline load is going to confirm the diagnosis. So if they ask you, if they tell you, oh, this patient presents with hypertension, hypokalemia, their aldosterone levels are elevated, they have low renin, you're thinking that it's primary hyperaldosteronism, but you want to make sure which of the following tests will confirm the diagnosis of primary hyperaldosteronism. And the answer is an adrenal suppression test after you give them oral saline. Okay, and then you have an abdominal imaging on CT, and adrenal venous sampling is used to distinguish between either unilateral adrenal adenomas or a bilateral adrenal hyperplasia. So how would you treat? If it's unilateral, if you have a unilateral adrenal adenoma, then surgery is preferred. You can also give them aldosterone blockers like spironolactone or eplerenone, but for poor surgical candidates or patients that are refusing surgery, that's the only time it's indicated to give them aldosterone blockers. So surgery is number one. If it's bilateral adrenal hyperplasia, then you can give them aldosterone blockers. In the case of resistant hypertension, then you can give them thiazides or ACE inhibitors. So edema and hypernatremia is going to be prevented by a mechanism of aldosterone escape, which is the most common cause of secondary hypertension. So the serum potassium may be normal initially, but the use of diuretics can cause significant symptoms with hypokalemia. So they'll have symptomatic hypokalemia. So the best screening test is an early morning plasma aldosterone to plasma aldosterone concentration to plasma renin aldosterone ratio. So drugs that are gonna alter that ratio, the aldosterone to renin ratio, are gonna be like spironolactone, that can alter it, eplerenone, amiloride, triamterene. Those should be discontinued 4 weeks prior to testing because remember, those are aldosterone blockers. Or aldosterone antagonists, same thing. So here's I'm going to describe to you a little diagram here, the pathogenesis of primary hyperaldosteronism and aldosterone escape. So they could present with bilateral nodular hyperplasia or a hyperfunctioning adrenal adenoma, and both of those scenarios are going to cause high aldosterone levels. Because you have high aldosterone, that's going to lead to a decrease in potassium reabsorption. So because you're not absorbing potassium, you're going to lead to low levels of potassium in your blood called hypokalemia, and that's going to lead to an increase in bicarbonate, renal resorption, and an increase in the secretion of hydrogen ions. So this is a hypokalemic state, or alkalosis, basically. Also, because it's alkalosis, you're going to have a decrease in hydrogen reabsorption. So because you're peeing out all that hydrogen, you're going to lead to a metabolic alkalosis. Again, that's the high bicarbonate and renal resorption, renal reabsorption and increase in hydrogen secretion. And then because you have high aldosterone, you also have increase in sodium reabsorption. So because you have high sodium levels, that's what's going to give you the hypertension or the high blood volume, which is going to lead to a low renin state, because if you have hypertension feedback inhibition will decrease renin and will decrease angiotensin II. But what happens normally is that renin and angiotensin, if they're decreased, aldosterone should be decreased. So here you have your low renin, low angiotensin II, and you have high aldosterone. There's your hyperaldosteronism. So because you have a hypertension and high blood volume, you're going to have increase in renal blood flow because of that high blood volume. Because you have high blood flow, then your GFR is going to be increased, as well as your atrial natriuretic peptide, because the AMP is that peptide that sees the heart expanding, right? So AMP increases in heart failure because the heart is expanded because of all that blood flow. Same thing here. You have increase in blood volume. So that's going to lead to increasing sodium excretion. And that's called your aldosterone escape. So we said earlier that sodium is reabsorbed and it causes the hypertension and the high blood volume. But there comes a point where you have too much blood volume and your body just then starts excreting that blood volume just on the basis of physics and BMP. So because of that, your sodium reabsorption is not going to be as much as the sodium excretion happening because of that high BMP. And that is called your aldosterone escape, which limits the edema, and it also limits the hypernatremia. So you can only have so much edema and so much hypernatremia until your body basically rejects that. And that's called aldosterone escape. Okay, cool. Next is your pheochromocytoma. So pheochromocytomas and paragangliomas are basically two catecholamine secreting tumors. And they're located in chromaffin cells, specifically of the adrenal medulla and the extra-adrenal paraganglia, and that's respectively. There's intermittent or sustained hypertension. There could be pallor due to the vasoconstriction. And there's a paroxysm of severe hypertension that could be precipitated by an increase in intra-abdominal pressure. Supposedly, let's say, for example, by a tumor. So palpating a tumor and positional changes, as well as surgical procedures and a number of medications, particularly an anesthetic agent. So moving on, we have the pituitary gland. So we're going to talk about hypopituitarism, and some of the clinical features of hypopituitarism would be divided into like hypothalamic causes or pituitary causes. So for the pituitary causes, you have primary or metastatic masses, and that would be like an adenoma. Another cause of hypopituitarism in the pituitary would be infiltration like hemochromatosis or lymphocytic hypophysitis, and as well as hemorrhage. So in hemorrhage, you have something called pituitary apoplexy, or there could be an infarction of the pituitary, like in Sheehan syndrome. Hypothalamic causes of hypopituitarism would be like mass lesions, could be radiation therapy, it could be infiltrative diseases like sarcoidosis, or blunt trauma to the base of the skull, or infections like TB and meningitis can all cause hypothalamic hypopituitarism. So how would they present? Well, it's an ACTH deficiency that's secondary. It's a secondary adrenal insufficiency. They'll have postural hypotension, tachycardia, fatigue, weight loss, hypoglycemia, and eosinophilia. So it could be hypothyroidism as well. Hypothyroidism they can present with hypothyroidism if it's central. So they'll have fatigue, cold intolerance, constipation, dry skin, bradycardia, and slowed deep tendon reflexes, as well as gonadotropins. In women would be they would present with amenorrhea and infertility, and in men, they'll also have infertility and a loss of libido. Okay, so a prolactinoma. So let's look at the overview here of a prolactinoma. Clinical features in premenopausal women, it would be oligo or amenorrhea. They can present with infertility, galactorrhea or hot flashes, as well as decreased bone mineral density. In postmenopausal women, that could be due to a mass effect symptoms such as headaches or visual field defects for prolactinoma. And in men, prolactinomas can present with infertility, a decreased libido, impotence, and gynecomastia. So kind of similar to hypopituitarism. On lab imaging, their serum prolactin levels are going to be in excess of 200 nanograms. You want to rule out renal insufficiency due to creatinine and hypothyroidism. So you want to check thyroid stimulating hormone as well as thyroxine levels. And you also want to do an MRI of the brain and pituitary to see if there is a mass there. Treatment would be like carbergoline, which is a dopamine agonist, or straight transsphenoidal surgery to remove the prolactinoma if possible. And that would actually be definitive. So management of a hyperprolactinemia in premenopausal women. So first of all, they would require a detailed clinical evaluation, and you'd want to rule out any kind of secondary causes of hyperprolactinemia, such as pregnancy. Okay. Then once you do that, then you can MRI the pituitary gland. If they're asymptomatic and they have prolactin levels of less than 10, so that's like a microprolactinoma, then you don't treat. Okay, so if the the actual tumor itself is less than 10 millimeters, then that's asymptomatic and no treatment is required. However, if their prolactinoma, their tumor, is actually greater than 10 millimeters, or if they're symptomatic, or if they have a less than 10 millimeter tumor, but it's symptomatic, then you can actually do two things. You can either give them dopamine agonists in the form of carbergoline or bromocriptine, or you can surgically resect it if the tumor is really large, in excess of 3 centimeters, or if it increases in size while they're on treatment like carbergoline or bromocriptine. So if they're on treatment and it's still increasing in size, you just want to resect it, because that's just telling you that treatment isn't working. All right. So growth hormone secreting pituitary adenoma is our next topic. So let's say you have a clinical suspicion for acromegaly. Okay, their hat doesn't fit anymore, their bones, the pictures of themselves, they don't look the same way as they did, say 10, 20 years ago. So what do? If you clinically suspect acromegaly, you want to check the IGF-1 levels. And IGF-1 levels are going to either be normal or elevated. If they're normal, that rules out acromegaly and you're done. But however, if IGF-1 is elevated, you want to do an oral glucose suppression test. And with that suppression test, you're going to see if growth hormone is either suppressed or if growth hormone doesn't suppress. So if it suppresses with the oral glucose suppression test, that rules out acromegaly. But if growth hormone doesn't suppress, then you want to move forward and do an MRI of the brain. Now, in the MRI of the brain shows up, and you can either have a mass in the pituitary or a normal pituitary. So if there's a mass in the pituitary, then you got to ask yourself, do I want to treat surgically or do I just want to manage them medically? But if their pituitary gland is actually normal, then you want to evaluate for extra pituitary causes of acromegaly, such as if they're taking ectopic growth hormones, or if they have a growth hormone related GHRH secreting tumor. So the following are some non-cardiac causes of death in patients with acromegaly. So strokes, the incidence of strokes is higher in patients with acromegaly. Colon cancer, in colon cancer, the condition is thought to occur with increased frequency. Renal failure can result from hypertension and hyperglycemia. And an adrenal failure can occur due to the hypothalamo-pituitary problems, due to a pituitary tumor. Although surgical resection and radiotherapy of the pituitary tumor can also cause secondary adrenal failure. So what are some of the common clinical features of untreated acromegaly? So you'll have a local tumor effect, so the pituitary enlarges, and it can cause visual field defects. It can give you headaches or cranial nerve defects. In the skin or in the muscles, it can cause gigantism, a mal-occluded jaw, so you have a very large jaw, arthralgias, arthritis, proximal myopathies, hyperhidrosis, skin tags, and carpal tunnel syndrome as well. Cardiovascular causes, well, they'll have cardiomyopathies, they'll have hypertension, heart failure, and valvular disease. And the valvular diseases are specific to mitral and aortic regurgitation. If you see the actual where this is leading to, so if you see the whole picture, acromegaly, everything's enlarging, the heart's enlarging, cardiomyopathy, hypertension, heart failure is enlarged heart, because that heart is stretching. The distance between each valve leaflet also stretches, and that causes a regurgitant valve. So there you have your mitral and aortic regurgitation. For pulmonary and GI symptoms features in acromegaly would be like sleep apnea, narcolepsy, colon polyps or colon cancer, as well as diverticulosis. They can also present with enlarged organs. So not only do they have like cardiomyopathy, but they also have a large tongue. They can have a large thyroid, salivary glands, a large liver, spleen, kidney, and prostate as well. And endocrine causes in acromegaly would be like galactorrhea, a decreased libido, diabetes mellitus, hyperparathyroidism, and hypertriglyceridemia. And basically, acromegaly arises from somatotrophs, and its most common cause of death, again, is because of the heart. Cardiovascular causes, including coronary artery disease, cardiomyopathy, left ventricular hypertrophy, arrhythmias, diastolic dysfunction. So 30% of patients have hypertension as well. So the treatment of acromegaly is to markedly decrease cardiovascular mortality. So that's what you should emphasize mostly on, because it's such a high mortality, the cardiovascular causes. So what are some of the non-functioning pituitary adenomas? So a non-functioning pituitary adenoma arises from a gonadotroph in the pituitary gland. Gonadotrophs, they normally secrete LH and FSH and alpha and beta subunits. So the beta subunit is going to be different in both. An adenoma is going to secrete an alpha subunit, and that's mainly non-functioning adenoma. So an adenoma means alpha subunit, and that means non-functioning. Whereas a beta subunit can be either or, and it could be different in both. So a pituitary adenoma can also be a space-occupying lesion, and that can cause hypofunctioning of whatever gland is remaining that's working. And that's going to lead to a decreased levels in LH. Low LH levels mean low testosterone, and that's central hypogonadism. And that leads to a decrease in TSH. And a low TSH is going to lead to low thyroxine levels, and that is central hypothyroidism. There can be a mildly elevated prolactin because of a disruption of normal dopamine inhibitory pathways. In a prolactinoma, the prolactin levels are going to be through the roof, more than 200. And remember, the diagnosis is not established until the tumor is going to be large enough to cause a mass effect. Okay, next topic is Sheehan syndrome. Sheehan syndrome is basically heavy peripartum blood loss that's complicated by hypotension or blood transfusion, causing an infarction to the pituitary in a postpartum patient. So just see clinical features would be like symptoms of hypopituitarism, so low prolactin levels, decrease in ACTH, decrease in TSH, FSH, LH, or growth hormones. So how will they present? They'll present with amenorrhea. Non-lactating women typically are going to resume menses 10 weeks postpartum. So if they haven't resumed menses 10 weeks after, you should start thinking about Sheehan syndrome if you haven't thought about it beforehand. There could be lactation failures, loss of sexual hairs, anorexia and weight loss, lethargy, and hyponatremia. So just remember, Sheehan syndrome is going to be the clinical scenario is going to be a patient that presents with extreme heavy hemorrhaging and bleeding during labor, and whatever manifestations happen thereafter are going to be due to that pituitary gland being infarcted. Okay, symptoms can occur in immediate postpartum periods, or they can happen several days later. Management would be evaluation of the pituitary hormones and to replace those pituitary hormones if needed. So now we're going to go over the differential diagnosis of hyperandrogenism in females. So for instance, the diagnoses are going to be PCOH, non-classical congenital adrenal hyperplasia, ovarian adrenal tumors, hyperprolactinemia, Cushing syndrome, and acromegaly. So how are they going to present each one of them? How their features going to be? So in PCOS, features in females would be an oligoovulation, clinical or biochemical hyperandrogenemia. They can have polycystic ovaries on imaging, and there's no evidence of another diagnosis. So PCOS, is a problem with androgens. So they're hyperandrogenemia. There was a little mnemonic that said mandrogens. So in PCOS, they're very male, a lot of male features, a lot of androgens, very hairy female. So think that, and then think of the diagnosis of PCOS. And remember, polycystic ovaries aren't necessarily required to make the diagnosis of polycystic ovarian syndrome. Go figure, but that's the way it is. For non-classical congenital adrenal hyperplasia, they can also present with oligoovulation as well as hyperandrogenemia. So here's a problem, but they have increased levels of 17-hydroxyprogesterone levels. And that's what's going to differentiate between PCOH and non-classical congenital adrenal hyperplasia. I think I mentioned that earlier, to look out for the differential there. Ovarian adrenal tumors are going to present in an older patient with rapidly progressive symptoms. Their androgen levels are going to be extremely high, more than 3 times the upper limit of normal. But for ovarian adrenal tumors, look for a patient that's very old and that the symptoms are happening very quickly. Remember, we said earlier, hirsutism that is happening extremely fast. Think of an adrenal tumor in an older patient. Hyperprolactinemia is going to cause amenorrhea or galactorrhea with an increase in prolactin levels. Cushing syndrome is going to present with Cushingoid features. They're going to present with non-suppressible dexamethasone suppression test. So you do the dexamethasone suppression test and it doesn't suppress. And there's going to be a high 24-hour urinary free cortisol as well. And then finally, acromegaly, we said excessive growth, high levels of growth hormone, and high levels of IGF-1, which is insulin-like growth factor 1. Okay, so hirsutism can also be idiopathic, and that's due to excessive conversion of testosterone to DHT in the hair follicles, and that's usually positive. There's usually a positive family history of this, and they do not have virilization. 17-hydroxyprogesterone and androgens are usually normal. versus an ovarian or adrenal tumor, that's going to be, again, a rapidly progressing androgen symptoms like hirsutism and virilization caused by an ovarian or adrenal tumor secreting excess amounts of androgens. You'd want to measure testosterone and DHEAS as your initial workup. So if they say, a 50-year-old or a 60-year-old is going to present with hirsutism or virilization for the past month, and she's coming in, she's like, what's up? What's going on? What are you going to do next is you're going to order testosterone and DHEAS levels. That's your initial workup. If the testosterone is high, but the DHEAS is normal, that's an ovarian tumor, because that's a tumor that's pumping out a lot of testosterone without DHEAS as its surrogate. But if your DHEAS levels are high and relatively normal testosterone, then that's an adrenal tumor. So DHEAS, the A in DHEAS is A for adrenal tumor, and testosterone, high testosterone would be an ovarian tumor. It's a good way of remembering that. DHEAS is specific for adrenal glands, and it is sulfated. It's a sulfated form of DHEA, and DHEA is produced by both ovaries and testes. All right, moving on. That was primary amenorrhea. Now we're going to do secondary amenorrhea. So how do you evaluate secondary amenorrhea? So here you have amenorrhea for menses that happens more than 3 cycles or for more than 6 months. What are you going to do first? Obviously, you're always going to check a beta HCG when anyone presents with amenorrhea, right? So beta HCG, if it's positive, it's pregnancy. That's it, you're done. But most likely, if they're asking you for secondary causes of amenorrhea, they're going to want you to go a little bit further. So the beta HCG might be negative. If it's negative, what are you going to do next? You're going to check for serum prolactin. You're going to check TSH and FSH. And you're also going to check if they've had any type of prior uterine procedures or infections. And if so, then you'd want to do a hysteroscopy. But check prolactin, TSH, and FSH if the beta HCG is negative. So let's say the prolactin is increased. What do you do next? High prolactin, you're thinking prolactinoma, so brain MRI. All right, what about if the TSH is increased? What do you do? High TSH, you're thinking hypothyroidism. High TSH is usually found with thyroid problems, so hypothyroidism. And then high FSH, if you see high FSH on labs, that's a premature ovarian failure. So what are some of the common causes of hypogonadotropic hypogonadism in males? So that's a mouthful. Hypogonadotropic hypogonadism. So the common causes in men are going to be gonadotrophic cell damage, so either by a tumor or by trauma or by suprasellar surgery or radiation. Also, infiltrative diseases and pituitary apoplexy can all cause cell damage to the gonadotrophs, causing a hypogonadotropic hypogonadism. Prolactinomas can cause it. Cushing's syndrome due to endogenous Cushing's syndrome or iatrogenic Cushing's syndrome. Narcotic use can cause hypogonadotropic hypogonadism. Severe systemic illnesses, diabetes mellitus, hemochromatosis, anabolic steroids and testosterone use, as well as morbid obesity. Alcoholic intake can cause hypogonadism, and it does this by suppressing LH release from the pituitary or by directly inhibiting testosterone production from the testes. All right, next topic is gynecomastia. So what are some of the common pathological causes of gynecomastia? So gynecomastia is either caused by either increased estrogen production or peripheral conversion of testosterone to estrogen, or estrogen, increased conversion to estrogen, or it could be because of androgen deficiency. So if it's an increased estrogen production or peripheral conversion, this is due to either testicular tumors, adrenal tumors, or human chorionic gonadotropin secreting tumors. It could also be due to cirrhosis or malnutrition, a thyrotoxicosis, congenital excessive aromatase activity can do it because you're constantly converting testosterone into estrogen, that's aromatase, as well as androgen use. And drugs like spironolactone, which are aldosterone blockers, they also have effect on androgen, so you increase estrogen this way with spironolactone, cimetidine, which is a histamine blocker, and herbal products like tea tree oil and lavender oil. Both those have an effect on estrogen levels by increasing them. Androgen deficiency. Primary or secondary male hypogonadism is a cause of androgen deficiency, Klinefelter syndrome being one of them, and damage to the testicles themselves. Testicular damage can cause a primary or secondary male hypogonadism, as well as hyperprolactinemia and renal failure. And remember that approximately 2/3 of pubertable boys develop gynecomastia, so that's normal, and it usually resolves around in a couple of months to 2 years without any type of need of intervention. But if the gynecomastia is persistent, you want to look for other causes. All right, next topic is metabolic syndrome. So what are some of the features of metabolic syndrome? You have hypertension, impaired glucose tolerance, and dyslipidemia, and patients are characteristically overweight with an increased waist to hip ratio. There's insulin resistance. That's going to be the main cause of metabolic syndrome. And there's 3 or more diagnostic criteria required. So out of the 5 that I'm going to say, you're going to need 3 of them. So abdominal obesity is one of them. In men, there's a waist circumference of more than 40 inches, or women with a waist circumference of more than 35 inches. A fasting glucose levels of 100 to 110. Blood pressures of more than 130/80. Triglycerides if they're more than 150, or if HDL levels are less than 40 in men or less than 50 in women. If you have 3 of those following, that meets the diagnostic criteria of metabolic syndrome. And other features of insulin resistance that's not involved in metabolic syndrome are going to be like endothelial dysfunctions, procoagulable states, high sympathetic activity, high markers of inflammation, decreased uric acid excretion, high sodium absorption, and disordered breathing, as well as increase in testosterone secretion by the ovaries and impaired endothelial-dependent vasodilation. All right, so since we're on the topic of metabolic syndrome, and we just actually finished it, the next one is going to be diabetes mellitus. So diabetes screening. The current guidelines for screening diabetes mellitus is the following. So in the U.S. Preventive Task Force, or the USPSTF, is going to recommend screening patients with sustained blood pressures, treated or untreated, of more than 135/80. However, there is insufficient evidence to establish the benefits of screening patients with blood pressure that's less than 135/80. And then the other current guideline is with the American Diabetic Association, which recommends screening in all patients that's greater than 45 years old, as well as those at any age with any additional risk factors for diabetes. And what are some of the diabetic risk factors? So some of the risk factors, if your BMI is more than 25, would be physical inactivity, if you're just sitting down or in bed all day long, all the time. First degree relatives with diabetes, a high risk of race or ethnicity, so African Americans, Latins, Native Americans, Asians, and Pacific Islanders have a high risk of diabetes. Women whose children's birth weight were more than 9 pounds in their macrosomach have an increased risk of diabetes. Any type of history of gestational diabetes puts you at risk. Hypertension or prior cardiovascular disease. Dyslipidemia, which which would be like a low HDL and high triglyceride levels, and history of polycystic ovarian syndrome, as well as a history of glucose intolerance. So how would you screen for glucose intolerance and type 2 diabetes? Well, first you'd want to do a 75-gram 2-hour oral glucose tolerance test, and that's the preferred method. But if the oral glucose tolerance test is not feasible, then you can just do a fasting blood glucose. No calories for more than 8 hours, and glycosylated hemoglobin, so the hemoglobin A1C, that's not sensitive in detecting glucose intolerance. So patients with increased risk of diabetes have the following values. So if their fasting blood glucose is 100 to 125, or if they have a 2-hour oral glucose tolerance test that's 140 to 199, or if their hemoglobin A1C is at 5.7 to 6.4%, which is 39 to 46 milliosmoles, that would put you at high risk of diabetes. Now, to make a diagnosis of type 2 diabetes, your fasting glucose should be more than 126. Hemoglobin A1C would be more than 6.5%. A 2-hour oral glucose tolerance test would be 200 milligrams, and a random plasma glucose would be more than 200 milligrams with symptoms. With symptoms is important. So what are the tests used for screening diabetes? So as we said earlier, hemoglobin A1C, that's the preferred test in a non-fasting state. If it's more than 6.5%, that gives you the diagnosis of diabetes mellitus. But if it's in between the ranges of 5.7 to 6.4%, that just gives you an increased risk for diabetes. And if your hemoglobin A1C is less than 5.7, that's normal. Other screening tests would be your fasting blood glucose. So in that, you can't eat anything for 8 hours. And if you don't eat anything for 8 hours and you have more than 126 milligrams per deciliter of glucose in your body left over, that is the definition of diabetes mellitus. Or if you have 100 to 125 milligrams per deciliter, that just puts you at increased risk for diabetes. But if it's less than 100, then it's normal. A random blood glucose level of more than 200 gives you the diagnosis for diabetes mellitus with symptoms. But if it's between the ranges of 140 to 199, that's increased risk for diabetes, and less than 140 is normal. And then an oral glucose tolerance test, that's going to be the most sensitive test. It's a 75-gram glucose load with glucose testing for 2 hours. Any test that's more than 200 milligrams is going to give you the diagnosis of diabetes. 140 to 199 puts you at increased risk for diabetes, and less than 140 is normal. So that's kind of like the random glucose level. So these testings may be repeated in cases of discordant or equivocal results. So if you don't really get anywhere with what you just did, you can repeat your tests. Or if a patient is asymptomatic but a positive test should be reconfirmed with the same test on a different day. That's what I was saying earlier about that you have to also be symptomatic, because if the patient's asymptomatic, then you kind of want to do it again just to confirm it. Now, what are some of the complications of diabetes? So you can have cardiovascular complications, you can have peripheral nerves complications, GU complications. So let's go one by one. So in cardiovascular complications, they can give you tachycardia, impaired exercise tolerance, postural hypotension with loss of diurnal blood, pressure variations. On your peripheral nerves, you can get dry skin, itching or pruritus, callus formations, foot ulcers, and poor wound healing, and something called Charcot's arthropathy, which puts you at increased fracture risks with resultant secondary ulcerations. GI complications could be gastroparesis, because the intestines, the nerves for the intestines are not going to be working very well. So gastroparesis with delayed gastric emptying, esophageal dysmotility with possible dyspepsia, and intestinal involvement with possible diarrhea, constipation, or fecal incontinence. GU symptoms would be like erectile dysfunction and retrograde ejaculation in men, and a decreased libido and dyspareunia in women. Now for the retrograde ejaculation, this is a parasympathetic innervation of the bladder, and that's going to regulate the detrusor contraction and the internal sphincter relaxation. That causes voiding, and then neurogenic bladder dysfunction causes urinary retention and bladder distension, as well as post-void residual volumes of more than 50 milliliters, and symptoms can occur clinically both day and at night. There's also going to be a decreased ability to sense a full bladder, like we said, leading to incomplete bladder emptying and decrease in urination. And eventually, there's going to be recurrent urinary tract infections and overflow incontinence, so they'll present with dribbling or poor urinary stream. So the following are going to be effects of intensive glycemic control in type 2 diabetes. You either have macrovascular complications like in an acute MI or a stroke. There will be no change or possible long-term decreases in the complications. Microvascular complications like nephropathy and retinopathy also have a decrease, and mortality has no change in the glycemic control. So hemoglobin A1C is between 6 to 7%, or it could be increased at less than 6%. So a recommended tight glycemic control is used to prevent microvascular complications, which include hemoglobin A1C of 6 to 7%. And for the prevention of macrovascular risk, control of other factors like smoking, you want to control BP, and you want to control lipids, and that's important. And as well, tight glycemic control increases the risk of hypoglycemia. So I've found that it's rarely ever the correct answer because of the increased risk of hypoglycemia if you're undergoing tight glycemic control. So for neuropathy, 50% of patients get neuropathy, and it depends on the duration of the disease as well as the level of control. Neuropathy can be either distal or symmetrical, distal symmetrical sensomotor polyneuropathy, with proximal motor neuropathy as well as mononeuropathy, and that can be cranial, so the cranial nerves 3, 4, or 6, or it could be peripheral nerves like the radial, the median nerve, or the perineal nerve, or it could be autonomic neuropathy. For distal symmetrical sensomotor neuropathy, that's going to be the most common. So they have what's called the stocking glove neuropathy, which increases in incidence in patients with risk factors of atherosclerosis. So you'll have patients with dyslipidemia, hypertension, smoking, or obesity, and that's when they have that stocking glove neuropathy. Sensory involvement is going to depend on the type of nerve involved. So there could be either pure small nerves, large nerves. So for the small nerve fibers, they're going to present with more pain and allodynia, as well as paresthesias, and sensory loss is not as marked, and ankle jerks are preserved. So here, when a patient comes in with neuropathy, with pain in their nerves, it's most likely due to a small fiber nerve, versus a pure large fiber that's less painful, but they'll have more numbness involved. They also have pressure, proprioception, vibration is going to be decreased, ankle jerk loss, and also the neuropathic pain is also characteristically present at rest, or it could be worse at night. So as the diabetic neuropathy progresses, there could be pain which subsides, but the sensory loss is going to persist. And the treatment is difficult to treat, but treatments are like TCAs, gabapentins, or NSAIDs. Drugs like mexiletine, phenytoin, carbamazepine, topiramate, topical capsaicin cream has also been used. TCAs are going to worsen urinary symptoms because of the cystopathy and orthostatic hypotension. and that's due to cardiovascular diabetic nephropathies. And gabapentin is going to be an alternative for these patients if they cannot be on a TCA, so you would want to switch them to gabapentin or put them on gabapentin. And NSAIDs should be avoided in patients with renal dysfunction because NSAIDs are known to cause increases in creatinine and decreases in renal function. Autonomic neuropathy, this can cause esophageal dysmotility, so patients will present with dysphagia, gastroparesis due to the gastric symptoms, and intestinal functioning like diarrhea. They can get constipation or incontinence. They can get enteropathies, abnormal sweating, and postural hypotension, as well as cystopathy and erectile dysfunction. So what are some of the clinical features of gastroparesis? Will include like nausea, anorexia, vomiting, early satiety, and postprandial fullness. And it can cause hypoglycemia with insulin given before meals and with impaired gastric emptying and impaired absorption. The treatment for gastroparesis is to basically optimize the glucose control. You want to increase fiber intake and small frequent meals. Medications are used to improve gastric emptying like metoclopramide. Metoclopramide is a prokinetic and it's an antiemetic agent, so it's good for symptomatic relief, as well as it can cause extrapyramidal side effects, however, in less than 1% of the patients. Erythromycin is also more useful when given IV in acute conditions, and cisapride. But cisapride is restricted in its use in the U.S., and that's due to cardiac arrhythmias and death. So that's most likely not going to be on the exam, but look for metoclopramide or erythromycin. Antihistamines like promethazine and diphenhydramine are serotonin inhibitors, as well as like aldosterone and granisterone. They have more antiemetic properties, and they can be used in combinations with prokinetic agents when vomiting is the predominant symptom. Diabetic foot ulcers, the risk factors for these are diabetic neuropathies, a previous foot ulcer, vascular diseases, and foot deformities. There's three causes. It could be either peripheral neuropathy, microvascular insufficiency, or immunosuppression. And that usually has been undermined or punched out borders. The risk assessment here would be for the development of a foot ulcer is to do the monofilament test. So that's used to document peripheral sensory neuropathy. There's a monofilament that's placed on the plantar surface of the at a right angle with increasing pressures until the filament basically buckles and curves in. Patients with neuropathy have a higher pressure threshold and loss of monofilament sensations, which are associated with an increased risk of foot ulcers. Other sensory deficits are going to include a decrease in vibratory sense, it's measured with a tuning fork, and a decrease in pinprick, and a decrease in temperature. So just remember that for diabetic foot ulcers, the monofilament test is good, as well as the tuning fork. Place it on the malleus, as well as pinprick and temperature changes. That's about all you need to know. So foot ulcers can be classified as either grade 0 to 5. Grade 0 is high risk foot with an ulcer. Grade 1 is going to be a superficial ulcer with a full skin thickness involvement, but no involvement of underlying tissue. So a grade 1 and 2 would just require proper wound care, could maybe debridement and removal of all infected and necrotic tissue. Grade 2 would be a deep ulcer penetrating to the ligament or the muscle, but no bone involvement or abscess formation. So grade 1 through 2 is just basically superficial ulcers. A deep ulcer is grade 3 with cellulitis, an abscess formation, or osteomalitis. Here you have a short period of hospitalization. Surgical debridement is required, as well as culture of the material obtained from the deep ulcer, as well as a bone biopsy and IV antibiotics that'll cover gram-negative and anaerobic organisms, because here it will go all the way to the bone, causing osteomyelitis. Grade 4 ulcer is localized gangrene And then grade 5 is extensive gangrene that covers the whole entire foot. So grades 4 to 5 require urgent hospitalization and surgical consultation. So management is going to depend on the grade of the foot ulcer and the involvement of multiple disciplines. So there's 6 interventions that have been shown to be useful in the management of diabetic foot ulcers. So offloading would be number 1. So take some load off of your foot. Debridement, wound dressings, antibiotics, revascularization, and finally, if all those fail and it's just not getting any better, amputation is your last resort. Erectile dysfunction, the etiology, the meds, and the conditions like autonomic neuropathy, penile circulation abnormalities, and hypogonadotropic hypogonadism can cause ED. Hypogonadism can be either primary or secondary. In primary, you have low testosterone or a decrease in sperm count with an elevation in LH and FSH. Secondary hypogonadism, or central, has a decrease in testosterone and a decrease in sperm count, again, but they'll have a low or normal LH and FSH. So you want to measure prolactin levels, and if the prolactin level is increased, as well as testosterone is increased, then, or if you have visual field defects, you want to check for a pituitary dysfunction. So how you do that is by doing an MRI of the pituitary. If it's abnormal, you want to give a dopaminergic agonist. If they have normal prolactin and a normal MRI, then testosterone therapy is usually required. In obesity, obese type 2 diabetics have an increased risk of developing hypogonadotropic hypogonadism, which can lead to erectile dysfunction. And you also want to measure early morning total testosterone levels if you have erectile dysfunction. It's due to the circadian rhythm of testosterone in all diabetics to exclude testosterone deficiency. Moving on, we have diabetic ketoacidosis. So what are some of the patient characteristics here between diabetic ketoacidosis and a hyperosmolar hyperglycemic state? So that would be like your HONK syndrome. So in diabetic ketoacidosis, it's usually from type 1 diabetes, and it occurs at a younger age. They present with less pronounced altered mentation. They have more rapid onset of hyperglycemic symptoms, so the symptoms are really fast. Hyperventilation and abdominal pain are common. And on labs, the glucose levels are going to be between 250 to 500, so it is high, but it's not as high as hyperosmolar hyperglycemic. So the glucose in diabetic ketoacidosis is less than 500, between 250 to 500. Bicarbonate levels are going to be low at less than 18 because this is an acidosis. There's an elevated anion gap. So remember that mud piles, mnemonic. There can also be positive serum ketones, obviously, because it's a ketoacidosis. And serum osmolarity is going to be less than 320 milliosmoles. Versus hyperosmolar hyperglycemic state, and that's usually found in type 2 diabetes, and type 2 diabetics are usually older. They present with more pronounced altered mentation. They have gradual onsets of hyperglycemic symptoms, and hyperventilation and abdominal pain is going to be less common. Versus diabetic ketoacidosis, you're going to have hyperventilation because you're going to try to compensate for the acidosis. In laboratories, the laboratory studies are going to be in hyperosmolar hyperglycemic, a glucose level that's through the roof, more than 600. Bicarbonate levels are going to be increased at 18 because it's not an acidosis, it's a hyperosmolar state. Their anion gap is normal because it's not part of the mud piles mnemonic. Well, there's not just because of that, but you know what I mean. Also, there's a negative or small serum amounts of ketones because this is in a ketoacidosis, and their serum osmolarity is going to be way more than 320. So there's your hyperosmolar hyperglycemic state. So in a diabetic ketoacidosis, we said that it happens in a young age. Young people are more at risk, not more at risk, but type 1 diabetics happen more in young age, and it can be an initial manifestation of diabetes. Clinical symptoms for diabetic ketoacidosis: acute and subacute onset. Initially, they have polydipsia, polyuria, they can have blurred vision or weight loss, and later on, they can acquire altered mentation, hyperventilation, and abdominal pain. The diagnosis, remember, is glucose levels between 250 to 500. There's going to be decrease in bicarbonate because it's an acidosis, elevated anion gap, and positive serum ketones. Treatment would be to give them high flow IV fluids. That's the most important one. First treatment is to give them lots of fluids. Then you can give them insulin IV, and then you want to follow and replace the potassium. So bedside capillary blood glucose can be obtained in seconds, and treatment should be initiated while awaiting the confirmatory tests. So you don't want to wait for the tests. You can just go straight to treatment, especially if it's just giving them fluids and insulin. Abdominal pain and tenderness correlate with the severity of the disease, and infections can be precipitated in diabetic ketoacidosis. An infection leads to an increased amounts of catecholamines and cortisol release. So when cortisol gets released, because you're in that stressed acidotic state, glucagon is going to increase, and you get hyperglycemia. You also get ketonemia, so lots of ketones in the bloodstream, as well as an osmotic diuresis. The osmotic diuresis is going to decrease the blood volume, and you'll have an activation of the renin-angiotensin system, causing you to have a net renal potassium loss. So this is why you want to give them lots of fluids. And then there's going to be an increase of potassium levels in your serum because there's a lack of insulin, and there's also acidosis. When you have acidosis, you have hyperkalemia. All right, now in hyperosmolar hyperglycemic, we said that this happens more commonly in elderly patients with type 2 diabetics. It's a gradual onset of symptoms, so they'll have gradual hyperglycemic symptoms like polyuria, polydipsia, and altered mental statuses. On labs, you'll see glucose levels of more than 600, even more than 1,000, and that can cause osmotic diuresis with a loss of about 8 to 10 liters of water. And hydration, again, is very important in these patients. However, in a hyperosmolar hyperglycemic state, the pH is going to be normal as well as the bicarbonate. The anion gap is going to be normal. They're going to have negative or small amounts of ketones in the serum, and the osmolarity here is going to be increased more than 320. So the plasma osmolarity is calculated by 2 times the plasma sodium plus the plasma glucose divided by 18. All right, so initial management of a hyperglycemic hyperosmolar state is to give them, again, aggressive hydration with normal saline and IV insulin. So, and you also want to do careful monitoring, supplementation with potassium. And the insulin that you want to give them IV is going to be regular or short-acting insulin. You don't want to do long-acting. Okay, triggers for hyperosmolar hyperglycemic would be like infections, an MI, stroke, trauma, burns, and drugs like thiazide diuretics. The thiazide diuretics, the reason here is that thiazide diuretics are going to decrease intravascular volume. Because you have low volume, you'll have a decrease in the glomerular filtration rate, and that's going to increase counter-regulatory hormones. That decrease in GFR is also going to decrease glucose excretion, and you'll have an increase in counter-regulatory hormones. High glucose production and low glucose utilization means osmotic diuresis. So there you go. In a hyponatremia of hyperosmolar hyperglycemic state, that's due to the osmotic shift from intracellular to extracellular space. So there'll be an increased urinary loss of with osmotic diuresis, and they'll have an increase in ADH secretion because their body's sensing that there's not enough water, and that's going to lead to free water retention. However, in chronic hyperglycemia, the antidiuretic hormone response and release will be decreased. So chronically, your body will just normalize that, but in the beginning, you'll have water retention with ADH as a response. Normal saline is going to be given within the first few hours of treatment, irrespective of the sodium levels, with a subsequent change to 0.45% normal saline if it's corrected sodium, and if it's normal or high, you want to give you want to check that on labs. So here, the correction of sodium isn't as important because they require so much hydration. All right, next topic is how would you manage DKA and hyperosmolar hyperglycemic states? So IV fluids, like we said, high flow, normal saline is initially recommended, and you want to add dextrose 5% when serum glucose levels are less than 200. Insulin is going to be initially continuous IV insulin, and you want to switch to subcutaneous or basal boluses of insulin for the following. You can, if they're able to eat, if their glucose is dropped less than 200 or their anion gap is less than 12. Also, if their serum bicarbonate levels are increased to more than 15. And you want to overlap subcutaneous and IV insulin by 1 to 2 hours. You want to get them on subcutaneous insulin as fast as possible. So potassium, you want to add IV potassium if the serum potassium is less than 5.2, and you want to hold off insulin for serum potassium at less than 3.3. If the serum potassium is less than 3.3, you want to hold insulin. And nearly all patients with potassium depletion, even with hyperkalemia. Bicarbonate you want to consider in patients if the pH is less than 6.9, or if the plasma bicarbonate is less than 5, or if they have severe hyperkalemia. Because the complications of bicarbonate would be cerebral edema, especially in children. There could be shifts of the oxygen dissociation curve to the left, and that causes a decrease in tissue oxygenation, as well as hypokalemia and alkalosis. Hence, it's given in only those conditions. Phosphate is another management of DKA and hyperosmolar hyperglycemic states. You want to consider if the phosphate levels are going to be less than 1, if there's cardiac dysfunction, or if there's respiratory depression, and you want to monitor calcium frequently. You also want to measure blood glucose every hour. You want to check electrolytes every 2 to 4 hours, and you want to check an anion gap every 2 to 4 hours. So electrolytes, checking anion gaps, electrolytes, and blood glucose are extremely important. And what are the best markers for the resolution of a ketonemia is, again, the serum anion gap, which measures unmeasurable anion concentrations in the blood that return to normal with the elimination of the keto acid ions. A direct assay for beta hydroxybutyrate, which is predominant. That's going to be the predominant ketone in DKA. So if you ever see beta hydroxybutyrate, that's a ketone, and that's found in DKA. Also, rises of serum bicarbonate and arterial pHs further confirm improvement. IV insulin therapy also lowers glucose by 50 to 75 milligrams per hour, but ketosis and acidosis are only going to resolve very slowly. So since we're on the topic of diabetes, what are some of the medications given for diabetics? So you have medications like metformin, like sulfonylureas, pioglitazones, the DPP-4 inhibitors, and the GLP-1 agonists. So let's break them down here. So metformin, it's a biguanide. It decreases hemoglobin A1C by 1 to 2%. So that's really good. And points to remember here is that it's an initial therapeutic agent for most type 2 diabetics. So it's going to be the first medication that a diabetic is put on. It's weight neutral. There's low risks of hypoglycemia, but there can be associations with lactose with lactic acidosis, as well as life-threatening. It could be a life-threatening complication. So the lactic acidosis is a problem with metformin, and that's a commonly tested question. Sulfonylureas also decrease hemoglobin A1C by 1 to 2%, and it's also generally added to patients with metformin failure. So if you have a patient that's recently diagnosed with diabetes, remember, first you start them off with metformin. This is just a general rule of thumb. You start them off on metformin, and if that starts to not work or doesn't work as well as you'd like to, you'd want to add on a sulfonylurea. Sulfonylureas, however, are associated with weight gain, and they can cause hypoglycemia as a main side effect. The pioglitazones, or the TZDs, these decrease hemoglobin A1C by 1 to 1.5%. They're used if they're unable to tolerate metformin or sulfonylureas. Side effects of the glitazones are going to be weight gain, edema, congestive heart failure, bone fractures, and bladder cancer. There's a low risk of hypoglycemia when used alone. So if the glitazones are used by themselves, there's a low risk, as well as if it's used in combination with metformin, there's a low risk of hypoglycemia. And here the advantage of a glitazone is that it can be used in renal insufficiency. Remember, we said that metformin causes lactic acidosis, and you should be careful with renal failure patients. But if they have renal insufficiency, glitazones could be used. There's an old mnemonic that said, get in the zone with glitazones. The zone meaning that, let's say you're playing golf. This was the mnemonic. If you're playing golf, you want to be in the zone, right? And who are people who play golf? Are elderly people who have risks of congestive heart failure and bone fractures and bladder cancer, stuff like that. So if you think of a golfer, think of a golfer trying to get in the zone to try to get that putt in from such a long distance. So think of that as the side effect profile for the glitazones. But they could be used for renal insufficiency, so that could be a testable topic, as well as the side effect of CHF. For the next drugs would be DPP-4 inhibitors, and these are drugs like sitagliptins or your gliptins. These decrease hemoglobin A1C only by 0.5 to 0.8%, so not that much. There's a low risk of hypoglycemia. They're weight neutral. It doesn't cause weight gain or weight loss. And it also can be used with renal insufficiency, but again, it doesn't decrease the hemoglobin A1C as much as the other medications. And then finally, you have your exenatide or your GLP-1 receptor agonists. These are possible second agents for metformin failure. So if you don't do well with metformin, you can switch them to a GLP-1, especially if they're trying to lose weight. So you'll see a patient who's a diabetic and he wants to lose weight, and you get all these diabetic medications on your options. Which one would you pick? You would pick the GLP-1 receptor agonist, like exenatide, because that is good for weight loss. And they also have a decrease in hypoglycemia risks, and it could be used alone, so that's another good thing, or it could be used in combination with metformin. And they're forgot if I mentioned this, but they decrease hemoglobin A1C by 0.5 to 1%. So not terrible, it's pretty good. So I would think that would be a very good alternative to metformin in patients. So guideline recommendations adding insulin to metformin. You want to add insulin if the hemoglobin A1C is more than 8.5. Insulin specifically increases weight, and there's an increased risk of hypoglycemia with insulin. So whenever you see somebody on insulin, or you're thinking of putting somebody on insulin, remember that weight gain is going to be a major side effect, as well as hypoglycemia. The DPP-4 inhibitors are going to increase endogenous incretins, and that's going to also improve glycemic control. So I didn't mention that, but the DPP-4 inhibitors, the gliptins, they increase endogenous incretins that help with glycemic control. All right, so next topic, moving on, is diabetes insipidus. So diabetes insipidus is either classified as primary polydipsia, it could be classified as central diabetes insipidus, or nephrogenic diabetes insipidus. So let's go one by one. So a primary polydipsia, here you have a defect. Your defect is that you have a high water intake. So this is patients that just come in complaining of excessive thirst. Usually they're on antipsychotics, or they're anxious patients. Usually a middle-aged woman that's constantly thirsty and is on an antipsychotic. Think of primary polydipsia. And because they have so much water intake, their sodium levels are going to be low, so they'll have hyponatremia. Versus central diabetes insipidus, this is due to a decrease in antidiuretic hormone release from the pituitary. So central meaning your brain, there's not enough antidiuretic hormone release. So it could be idiopathic, it could be due to trauma, it could be due to a pituitary surgery or an ischemic encephalopathy, which can infarct the pituitary. These are all causes of central diabetes insipidus. And here, on the other hand, you have a high serum sodium. So central diabetes insipidus, if you're not given anything other than a high serum sodium to distinguish it, that's your clue. In nephrogenic diabetes insipidus, your serum sodium is normal. Here in central, the thirst mechanism is also affected. In nephrogenic, the thirst mechanism is intact. So they're not very thirsty. They just have an increase in water intake to normalize sodium concentrations to some extent. So in nephrogenic diabetes insipidus, this isn't a decrease in ADH from the pituitary. This is your pituitary is fine, it's secreting it, but your kidneys are resistant to ADH. It's not sensing the antidiuretic hormone. It's caused by either chronic lithium use, so that's a big one. Hypercalcemia can cause nephrogenic diabetes insipidus, and hereditary causes like AVPR2 mutations. Those are all high yield. So how would you test this? So you have somebody who you're thinking has diabetes insipidus. You would first test with a water deprivation test. So if you have any of these patients come into your office or in the vignette and then say, what is the next best test? It's going to be to do a water deprivation test. So you don't want to give them any water. You want to deprive them of water 2 to 3 hours. And after you do that, you want to measure urine volumes and urine osmolarities every hour. Then you want to measure serum sodium and osmolarity every 2 hours. If the urine osmolarity stays high at more than 600, then that's primary polydipsia. Okay, but if it doesn't, if the urine osmolarity is stable on 2 to 3 consecutive hourly measurements, and a plasma osmolarity is more than 295, or plasma sodium is more than 145, then you want to administer desmopressin, and you also want to monitor urine osmolarity, and you want to monitor the volume every 30 minutes for 2 hours. However, if they do not have an urine osmolarity that's stable on 2 to 3 consecutively hourly measurements, you want to continue the testing until you've reached an endpoint. And remember that if you do give them desmopressin and you do monitor their urine osmolarity, central diabetes, the distinction between central diabetes insipidus and nephrogenic diabetes insipidus, again, is to check the urine osmolarity. Urine osmolarity is increased 50 to 100% in central, and there's not that much of an increase with nephrogenic. In diabetes insipidus, you'll have a hypernatremia that's euvolemic. In contrast, psychogenic polydipsia causes euvolemic hyponatremia. So typically it presents with severe polyuria and mild hypernatremia, and it's based on urine osmolarity. Diabetes insipidus is going to be divided into complete diabetes insipidus, partial diabetes insipidus. So complete diabetes insipidus is that the urine osmolarity is going to be less than 300. Actually, it's often less than 100. And partial diabetes insipidus is a urine osmolarity that ranges from 300 to 600. And other causes of nephrogenic diabetes insipidus is going to be like severe hypokalemia. They can have tubulointerstitial renal diseases. Medications can do it. Remember, lithium, demiclocycline, foscarnet, cidofovir, and amphotericin can all cause nephrogenic diabetes insipidus. So how would you treat nephrogenic is to discontinue the medication if the medication is the one causing the problem. So if they're on lithium, you kind of don't want to stop lithium. But if they're on something else like foscarnet or amphotericin, you want to stop that medication. You want to salt restrict them, and you want to put them on a selected diuretic such as amiloride. If it cannot be discontinued, like let's say the drug was lithium, then you want to check you want to do hydrochlorothiazide, do the water deprivation, and that's going to increase sodium and water absorption in the proximal tubule. The way you treat central diabetes insipidus, central was you had a problem with the pituitary not secreting enough ADH. So initial therapy here is to give them desmopressin. Intranasal desmopressin is preferred, or oral, but intranasal is preferred. And hydrochlorothiazide can be added for an additional effect of the desmopressin. All right. Moving on, we have testosterone deficiency. So features suggestive of testosterone deficiency are going to be incomplete sexual development, decreased libido and potency. There's going to be decreased early morning erections and gynecomastia, decreased secondary sexual characteristics like decreasing shaving frequency, small testicles. The normal adult testes vary from 4 to 7 centimeters in length and have about 20 to 25 milliliters in volume. And remember that prepubertal is going to be less than 3 milliliters measured by a Prater Orca diameter. I really doubt they're going to ask that. Testosterone deficiency also causes hot flashes, especially if there's severe hypogonadism, a low sperm count, and osteoporosis. So what are some of the testicular tumors? You have Leydig cell tumors. You can get choriocarcinoma, a teratoma, a seminoma, or a yolk sac tumor. So, for instance, a Leydig cell tumor, that's the most common stromal sex cord tumor, and that occurs in all age groups, including young children. And Leydig cells are the primary source of testosterone and are also capable of estrogen production due to the increase in aromatase efficiency. Remember, aromatase converts testosterone into estrogen. Tumor cells are going to increase estrogen production. Because you have a lot of estrogen, there's going to be a decrease in FSH and LH, and that's going to cause an endocrine manifestations to occur in about 20 to 30% of patients. And it's most commonly, you're going to see gynecomastia in prepubertal cases. So you'll have precocious puberty with gynecomastia with Leydig cell tumors. In a choriocarcinoma, this is a germ cell tumor that produces beta-HCG, so remember that. A teratoma is going to increase alpha-fetoprotein levels, or it can increase beta-HCG, and that's going to indicate a coexistence of other germ cell tumors. A seminoma is the serum markers are going to be normal in a seminoma. There's going to be an increase in beta-HCG in seminomas that contain syncytiotrophoblastic giant cells. And a yolk sac tumor is an endodermal sinus tumor, and the germ cell tumors are going to increase alpha-fetoprotein levels. So in PCOS, the diagnostic criteria we said earlier, we were just mentioning it, but now we're going to discuss PCOS, is that you're going to need more than 2 of 3 of the following. So the following are going to be something called the Rotterdam's criteria. Not that you need to know that, but it's androgen excess, so biochemical or clinical hirsutism, acne, androgenic alopecia. Remember, mandrogens are the PCOS problem. So androgen excess. You can have oligo or anovulation, and there's also an exclusion of other hyperandrogenic conditions. So you want to exclude like hypothyroidism, hyperprolactinemia, non-classical congenital adrenal hyperplasia, Cushing's syndrome, and androgen-secreting tumors. Some of the treatment options for PCOS would be, number one is weight loss, also combined hormonal contraceptives for hyperandrogenism and for menstrual dysfunction. So the contraceptives are good. Clomiphene citrate is good for ovulation induction. So if they're not ovulating and they want to become pregnant, you can give them clomiphene. And metformin for a coexisting type 2 diabetes mellitus. Some of the comorbidities of PCOS would be obesity, or somebody becoming overweight. That's a comorbidity. Glucose intolerance and diabetes mellitus. Also dyslipidemia. Because they're overweight, they can get obstructive sleep apnea and endometrial hyperplasia or endometrial cancer, unfortunately. Metformin also prevents diabetes in the very obese patients. So if, let's say, their BMI is more than 35, with impaired fasting glucoses and impaired glucose tolerances. So you can try metformin in these patients. And spironolactone, that's an anti-androgenic. Okay, and spironolactone is going to impair the development of male external genitalia in the fetus, and hence it's given to those who have absolute contraindications to oral contraceptives. And so what are some of the absolute contraindications to combined oral contraceptives, since we're on that topic? A migraine with an aura, shouldn't give them OCPs. More than 15 cigarettes a day, or if they're older than 35 years old. So you don't want to see them smoking and being on an OCP. Stage 2 hypertension, so blood pressures of more than 160 over 100. Histories of venous thromboembolic disease, history of strokes or ischemic heart disease, breast cancer, cirrhosis, and liver cancer, and any kind of major surgery with prolonged immobilization. You don't want to give them OCPs, as well as if they've been less than 3 weeks postpartum. That's not, you don't want to do that. You don't want to give them OCPs. What is refeeding syndrome? So refeeding syndrome, we're going to look at the pathogenesis of refeeding syndrome. So let's look at the fed state and the starvation state. So let's start off with the starvation state. So the starvation state puts you in a catabolic state. Your body's going to want to break down a lot of things to get itself going again because it's starving. So insulin levels are decreased, glucagon levels are increased, and cortisol levels are increased. Because of that, there's going to be a decrease in ketone body use in muscles, and there's going to be an increase in ketone bodies use in the brain. Also, there's an increase in glycogenolysis, so glycogen is going to start getting broken down. Fat or lipolysis is going to be increased, and so fat's being broken down, and protein catabolism is going to be increased. So you're going to break down a lot of fat, break down protein, and break down glycogen. And this is all going to cause a depletion of fat, a depletion of protein, vitamins, minerals, and intracellular electrolytes. Now, when you've gotten to that point and you start refeeding them, that would be an anabolic state, and that can basically lead to could lead to or not lead to, but like a carbohydrate ingestion of whether they have enteral or IV feeds. Your insulin levels are going to increase. Glycogen synthesis is going to start occurring, as well as protein synthesis and intracellular uptakes of phosphorus, potassium, magnesium, and thiamine. You can see where this is getting at. This is all happening very rapidly, so this is bad news. Low serum phosphorus, low potassium, low magnesium, low serum thiamine, increased sodium and water retention. So there's a lot of electrolyte imbalances going on right now very rapidly because of the refed state. And because of this, they can get arrhythmias, congestive heart failure, pulmonary edema, peripheral edema. They can get seizures and a Wernicke's encephalopathy due to a thiamine deficiency. So phosphorus is going to be your main electrolyte that's going to be depleted. And phosphorus is needed for energy, right? ATP, adenosine triphosphate. And its aggressive initiation of nutrition without adequate repletion of electrolytes is going to lead to a cardiopulmonary failure. Patients with anorexia have euthyroid hypothyroxemia, and that leads to a normal TSH and a normal to decreased serum thyroxine and triiodothyronine. So T3s and T4s are going to be decreased. Carbohydrate intake also causes a rapid decrease in renal excretion of sodium, and when fluid is given for rehydration, it's going to lead to a fluid overload. So be careful refeeding patients because of those electrolyte imbalances that can happen. Next topic is going to be carcinoid syndrome. So carcinoid syndrome, clinically, it's going to manifest itself as skin as flushing, telangiectasias, cyanosis. In the GI, it's going to manifest as diarrhea, cramping, specifically a secretory diarrhea. In the heart, it's going to cause valvular lesions, the right side of the heart, especially more than the left. You can have bronchospasms in the lungs or niacin deficiency. So they can lead to dermatitis, diarrhea, and dementia. Carcinoid syndrome is diagnosed with an elevated 24-hour urine excretion of serotonin, or that 5-HIAA. A CT MRI of the abdomen and pelvis is used to localize if there's a tumor involved that's secreting serotonin. An octrio scan is used to detect any types of metastasis, and an echocardiogram if the symptoms of carcinoid heart disease are present. And you would treat carcinoid syndrome with octreotide for symptomatic patients and prior to surgery with anesthesia. Surgery for liver metastasis. Serotonin syndrome commonly occurs in the distal small intestine and the proximal colon and the lungs, and most commonly it metastasizes to the liver. So serotonin syndrome is or carcinoid syndrome, is a metastatic disease that goes to the liver, and it secretes histamine. Carcinoid secretes serotonin as well as vasointestinal peptide, or VIP. Moving on, you have Zollinger-Ellison syndrome. Zollinger-Ellison syndrome's epidemiology happens between the ages of 20 to 50 years old. There's an 80% sporadic causes, and 20% with men type 1. Clinical features of ZE syndrome would be multiple and refractory peptic ulcers, so peptic ulcers that keep coming and don't go away. Also ulcers that are distal to the duodenum, as well as chronic diarrhea. Dyspepsia, reflux symptoms, abdominal pain, weight loss, diarrhea, and frank GI blood loss is also featured with ZE syndrome. Diagnosis is with markedly elevated serum gastrin levels, so you're looking at gastrin levels in excess of 1,000 milligrams, in the presence of normal gastric acid with a pH of less than 4. So there's nothing wrong with the pH. It's just a lot of gastrin. And how would you work these patients up? With an endoscopy. Endoscopy is used to reveal any type of ulcers, and occasionally it could reveal any type of primary duodenal gastrinoma, actually. And you can also do a CT MRI with a somatostatin receptor scintigraphy for tumor localization. High levels of gastrin are going to cause parietal cell hyperplasia, and that's going to cause an increase in gastric acid production. The high gastric acid production is going to inactivate pancreatic enzymes, and it can cause injury to the mucosal brush border, and that can lead to diarrhea and steatorrhea. And once a gastrinoma is confirmed, you want to screen for men type 1, because remember that men type 1 has can have a gastrinoma involved, with assays of parathyroid, ionized calcium, and prolactin. So what if you have a patient who has suspected gastrinoma? You're suspecting this patient has a gastrinoma. What do you do next? The first step you do next is an endoscopy. The endoscopy is going to show multiple stomach ulcers and thickened gastric folds. So after that, then you want to check serum gastrin levels. You want to see if they level off. And you want to see if you require PPIs. And if they do, they would require therapy for at least a week. The gastrin levels, if they're less than 110, then that's not a gastrinoma. So that's that's basically it. You've just ruled out a gastrinoma. However, if the gastrin level is more than 1,000, you want to check the gastric pH. And you also want to initiate PPI therapy for 1 week. Then when you're checking the pH, you want to see if the pH is going to be less than 4 or more than 4. If it's more than 4, then it's not a gastrinoma. But if it's less than 4, then you want to further test to localize for a gastrinoma. Now, what if you check the serum gastrin levels and you do the PPI therapy for a week, and your gastrin level is between 110 to 1,000 milligrams? Then you do something called a secretin stimulation test. If the secretin stimulation test is negative, then it's not a gastrinoma, you're done. But if it is positive, again, you want to check to see if where that gastrinoma is localized. So again, you suspect a gastrinoma, you do an endoscopy, and then when you do an endoscopy, you see that you have ulcers in the gastric mucosa. What you want to do next is check gastrin levels and initiate PPI treatment. If the gastrin levels are low, it's not a gastrinoma. If they're high, you want to check the pH. If the pH is high, it's not a gastrinoma. But if the pH is low, then you want to check further testing to find the gastrinoma. And if the gastrin levels are in between 110 to 1,000, you want to do a secretin stimulation test. And again, if it's the secretin stimulation test is negative, that's not a gastrinoma. If it's positive, you want to do further testing to localize the gastrinoma. So a fasting gastrin level should be measured, and you want to check the gastric pH. If gastrin is over 1,000, as gastrin may also be elevated due to failure of gastric acid secretion, so in, let's say, achlorhydria, then you want to do a secretin stimulation to stimulate the release of gastrin by the gastrinoma cells, and they inhibit normal G cell secretins of gastrin. And then calcium infusion study is done usually in patients who have had gastric acid hypersecretion and are strongly suspected of having a gastrinoma, despite having a negative screening test. Then you have calcium infusion, which can lead to an increase in serum gastrin levels. So if you give a patient calcium will increase levels of gastrin in patients with a gastrinoma. All right, next topic will be a glucagonoma. Now, clinical features of a glucagonoma are necrolytic migratory erythema, diabetes insipidus, gastrointestinal symptoms like diarrhea, anorexia, abdominal pain, and occasional constipation, as well as weight loss, neuropsychiatric disorders like ataxia, dementia, proximal muscle weakness. All those are how they present with a glucagonoma. So for necrolytic migratory erythema, this is an erythematous papules and plaques that are found on the face and the perineum and on the extremities, and the lesions are going to enlarge and coalesce over the next 7 to 14 days, so between a week to 2 weeks, with central clearing and blistering and crusting, and as well as scaling at the borders. And that's necrolytic migratory erythema found in a glucagonoma. Also, patients with diabetes mellitus, mild hyperglycemia can be easily controlled with oral agents and diet, and it usually does not require insulin. And gastrointestinal symptoms, we already said, diarrhea, abdominal pain, and also other findings would be like weight loss, neuropsychiatric symptoms like ataxia, and associations with venous thrombosis. Now, how do you diagnose a glucagonoma? Hyperglycemia with an elevated glucagon of more than 500 is diagnostic, as well as a normocytic, normochromic anemia that's most likely due to chronic disease or a glucagon that's directly affecting erythropoiesis, as well as abdominal imaging like a CT scan or magnetic resonance imaging or MRI is used to localize the tumor or localize metastasis. But what about an insulinoma? This is a beta cell tumor that increases insulin production and also increases C-peptide production and proinsulin production. Normally hypoglycemia, so patients with an insulinoma are going to have hypoglycemia because it's secreting insulin. and that causes a near complete suppression of insulin, which does not occur in an insulinoma. So you have loss of feedback inhibition with an insulinoma because it's not a physiological form of insulin. For a VIPoma, clinical features of a VIPoma would be that they present with watery diarrhea, hypo or achlorhydria, so they can have low chloride levels or no chloride levels due to a decrease in gastric acid secretion. There could be association with flushing, lethargy, nausea, vomiting, and muscle weakness and cramps. On labs, you'll see low levels of potassium, hypokalemia, due to an increased intestinal potassium secretion, as well as hypercalcemia due to increased bone resorption, hyperglycemia due to increased glycogenolysis. And stool studies are going to show secretory diarrhea with an increase in sodium and osmolar GLAB of less than 50. The diagnosis of VIPoma is basically done with watery diarrhea and a VIP level of more than 75. So if the vasoactive intestinal peptide is high with watery diarrhea, there's your diagnosis, and then you want to do an abdominal CT or MRI to actually localize the tumor in the pancreas, and it's usually found in the pancreatic tail. Common age groups that get the VIPoma are adults between the ages of 30 to 50 years old. Stool volume can be greater than 3 liters a day, so they can have that type of watery diarrhea. 60 to 80% have metastasized to the liver by the time of the diagnosis, and the treatment would be obviously IV volume depletion because of all that watery diarrhea, octreotide also to decrease the diarrhea, and possibly hepatic resection with if you have metastasis to the liver. Remember, octreotide is a synthetic somatostatin. Okay, so next one would be a non-beta cell tumor. These are usually large mesenchymal tumors, and they produce insulin-like growth factor 2, which is an insulomimetic. So they mimic the effects of insulin, and they bind to the insulin receptors as well. Because they bind there, they block insulin from the real insulin from binding to the receptor. So you'll have a hypoglycemia and a decrease in insulin. Low insulin levels because of the feedback inhibition, and then C-peptide and proinsulin are also going to be decreased. You want to measure insulin-like growth factor 2 on labs for a non-beta cell tumor. Now, for multiple endocrine neoplasia, that's obviously divided into MEN1, MEN2A, and 2B. MEN1 is caused by a single mutation in the MEN1 tumor suppressor gene, and that's found on chromosome 11. So remember all the ones. MEN1, chromosome 11, chromosome 11. MEN2A and 2B are caused by the RET proto-oncogene on chromosome 10. And so RET, spelled backwards, TER or 10, maybe that'll help. So chromosome 10, the RET gene is also responsible for familial medullary cancer of the thyroid. And so what are some of the classifications of multiple endocrine neoplasia? For type 1, it's divided into primary hyperparathyroidism, and that's usually the most common. At more than 90% are going to have hyperparathyroidism. Also enteropancreatic tumors at 60 to 70%. So gastronoma being the most common pancreatic tumor in MEN1, and they present between the ages of 20 to 50 years old with heartburn, abdominal pain, and diarrhea, as well as frank GI bleeding, which can also occur, as well as pituitary tumors. So MEN type 1 is associated with pituitary tumors, enteropancreatic tumors like a gastronoma, and primary hyperparathyroidism. MEN type 2A can cause medullary thyroid cancer, and that's the most common at 90%, as well as a pheochromocytoma, which is 40 to 50%, and a parathyroid hyperplasia, 10 to 20%. So type 2A would be your medullary thyroid, pheochromocytoma, and parathyroid hyperplasia. For type 2B, it also has medullary thyroid cancer as well as a pheochromocytoma, but they don't have parathyroid hyperplasia. What they have is mucosal and intestinal neuromas and the marfanoid habitus. So that's it. So Men 2B is going to be more aggressive than Men 2A. Other features of Men 2B include skeletal deformities like kyphoscoliosis, lordosis, etc. DNA testing for the RET proto-oncogene is a germline mutation. So that RET proto-oncogene is a RET germline mutation. Using PCR is going to be the most useful in screening and diagnosing for Men 2 syndromes. And that's going to be better than biochemical tests like calcitonin levels. Calcitonin levels will give you a positive test, and then you'll require an elective total thyroidectomy, as well as biochemical tests like 24-hour urine metanephrines and free catecholamines or plasma-free metanephrines are going to be needed to make the diagnosis of pheochromocytoma. So again, Men 2B is your pheochromocytoma, your medullary thyroid cancer, and your marfanoid habitus, so you'll have marfanoid body features, and mucosal and intestinal neuromas. So let's go over multiple endocrine neoplasia type 1. So in the pituitary adenomas, clinical features of pituitary adenomas are that they're pituitary tumors that are prolactin secreting. They're also growth hormone secreting and ACTH secreting. Or they could be non-hormone secreting. So that's the pituitary adenoma. For primary hyperparathyroidism, which is like the number one cause at more than 90%, clinically they present with multiple parathyroid adenomas or parathyroid hypoplasia, which typically it occurs between 20 to 40 years of age or earlier if there's sporadic cases or high recurrences after a subtotal parathyroidectomy. And because of the hyperparathyroidism, you'll expect hypercalcemia, and it could be asymptomatic or it could be associated with polyuria, kidney stones, or a decrease in bone mineral density. So primary hyperparathyroidism and pituitary adenomas, as well as pancreatic or GI tract tumors. And in this classification, you'll have your gastrinomas, which will present itself as recurrent peptic ulcers, or an insulinoma that's going to give you hypoglycemia, a VIPoma, which will cause that secretory diarrhea that we talked about, hypokalemia, and hypo or achlorhydria, as well as a glucagonoma, which can cause weight loss, and the necrolytic migratory erythema that we spoke about, and the hyperglycemia. Now, common causes of myopathy are going to be your connective tissue diseases, endocrine or metabolic causes, drugs can cause it, and other things like infections, traumas, and hyperthermia can cause myopathies. So common causes of myopathies with connective tissue diseases would be like polymyositis or metamyositis. There can be an inclusion body myositis, there can be vasculitis, or there can be an overlap of symptoms, and that would be a mixed connective tissue disease. For endocrine or metabolic causes, you have your hypothyroidism or thyrotoxicosis, you have Cushing syndrome, and you have electrolyte abnormalities like hypokalemia, calcium, and phosphorus are all going to be decreased. Drugs or toxins that can cause myopathy would be steroids, statins. Statins are notorious for causing myopathy. Zidovudine can cause myopathy, as well as colchicine. Alcohol, cocaine, and heroin can also cause myopathies. And like we said earlier, infections, trauma, and hyperthermia. So what are some of the important gluconeogenic substrates and steps? So we're going to go and take a step back to your step 1, and we're going to review the glucose metabolism. So glucose will become phosphophenolynyl pyruvate. I think I pronounced that right. Phosphoenol pyruvate. And then from that, it's going to become pyruvate via a pyruvate kinase. Now, pyruvate, things that stimulate pyruvate are going to be lactate, alanine, and other glucogenic amino acids. So then pyruvate is going to enter the citric cycle, the citric acid cycle, and it's going to be converted into oxaloacetate by pyruvate carboxylase. Oxaloacetate in the mitochondria starts off the citric acid cycle, and it basically goes around, stimulated by either glutamine or other glucogenic amino acids, and finally becomes malate. Then malate can either go back and become oxaloacetate through malate dehydrogenase, or malate can be shuttled out of the mitochondria with that malate shuttle outside of the mitochondria into the cytosol. That malate in the cytosol can also become oxaloacetate, and then that oxaloacetate in the cytosol becomes phosphoenolpyruvate with that enzyme phosphoenolpyruvate carboxykinase. And then once it becomes phosphoenolpyruvate can go back and become glucose all over again with glycerol 3-phosphate. And that would be your gluconeogenic substrate steps. So remember, glucose becoming phosphoenolpyruvate to become pyruvate and go down the cycle. And then when it goes back up from phosphoenolpyruvate to glucose, you need that glycerol 3-phosphate. So some pointers here is that progesterone analogs like medroxyprogesterone acetate and megestrol acetate, these are used to improve appetite and weight gain in patients with cancer-related anorexia or cachexia symptoms. So remember, megestrol is a good one, and medroxyprogesterone as well. And that concludes endocrinology for internal medicine. Next up is endocrinology for pediatrics. So pediatric endocrinology starts off at the thyroid gland, and we're going to talk about congenital hypothyroidism here. Congenital hypothyroidism can be either familial or sporadic, and the causes here would be thyroid dysgenesis, like thyroid aplasia, hypoplasia, or ectopic glands. And these are 85% of the cases are causes of congenital hypothyroidism, which is thyroid dysgenesis. Also, less common is your inborn errors of thyroid synthesis or thyroid metabolism, as well as transplacental maternal thyrotropin receptor blocking antibodies. And that is the least amount at 5%. So clinical features in congenital hypothyroidism, the etiology again is thyroid dysgenesis. That's the most common. Clinical manifestations is that the majority of infants are going to be asymptomatic. Symptoms include lethargy, a hoarse cry, poor feeding, constipation, jaundice, dry skin, and large fontanelles. So if you, these are all pathognomonic. So if you remember hoarse cry, that's a big key word right there, as well as jaundice, dry skin, and large fontanelles. There's a diagnosis is made with TSH levels. So TSH is going to be increased and free T4 levels are going to be decreased with hypothyroidism. That doesn't change. And most infants identified by newborn screening. The treatment for congenital hypothyroidism is going to be levothyroxine, and its dose is initially going to be very low at 10 micrograms, and then it's going to be titrated accordingly. But again, don't worry about dosages is for the exam. So it could be normal at birth due to the transfer of maternal hormones. So the thyroid hormones might be normal because of that maternal transfer. They can gradually develop apathy and abdominal bloating. There can be the pathological jaundice that we said, also difficulty breathing, noisy respiration, and that's part of your difficulty of breathing, hypothermia, and they can have a refractory macrocytic anemia, and that's about it. So next is going to be your neonatal thyrotoxicosis. So for neonatal thyrotoxicosis, this is your transplacental passage of maternal anti-TSH receptor antibodies. And this is usually found in the third trimester. For neonatal thyrotoxicosis, the antibodies are going to bind to that infant's TSH receptors and cause excessive thyroid hormone release. So that's a test question right there. Antibodies that bind to the TSH receptors on the infant, causing excess thyroid hormone release. Clinical features would be warm, moist skin, tachycardia. There could be poor feeding, irritability, and poor weight gain. And there could also be low birth weight as well as preterm birth. And the diagnosis is made again with that maternal anti-TSH receptor antibody. and more than 500% is normal. So remember, maternal anti-TSH receptor antibodies is what's going to make the diagnosis. And treatment is that it usually self-resolves within 3 months because that's when the maternal antibodies disappear. And but if not, there's another treatment called methimazole that you can give with a beta blocker. An elevated anti-TSH receptor antibody level can also occur despite the maternal treatment of Graves' disease and euthyroidism or hypothyroidism during pregnancy. There's going to be an increased risk if the maternal anti-TSH antibodies is greater than 5 times the upper limit of normal. So remember that anti-TSH antibodies are going to be increased. And there's severe cases of thyrotoxicosis that can result in symptomatic fetuses, such as fetal tachycardia, that's a big one, hydrops fetalis, or growth restriction. All right. So the next topic is obesity and precocious sexual development. So adipocytes or fat cells are going to either have an increase in insulin secretion, or there could be an increase in leptin secretion. So let's say you have your insulin secretion is going to be increased. So because of that, there's going to be adrenal androgen productions. The androgen productions in the adrenal are going to cause peripheral activations of adrenarche in the child, and that's going to cause the child to have a body odor, oily hair, and oily skin. They can even get acne, pubic hair, pubarch, and axillary hair. And on labs, there'll be a slight increase in DHEAS. There could be a slight increase in testosterone, but testosterone is going to be usually decreased. So look for DHEAS increased slightly. Then this peripheral activation of adrenarche is generally benign, but they can have significant risk factors for PCOS. Remember, PCOS has to do with androgens and type 2 diabetes mellitus, as well as metabolic syndrome, and especially those who are obese to begin with. The high insulin secretion is also going to cause ovarian estrogen production. So in the ovaries, estrogen is going to be overly produced with obesity, causing a peripheral activation of thyroid. And thyroid would be your breast development, uterine changes, and maturation of the ovaries. Now, we also said that adipose cells can cause an increase in leptin secretion. And what does that do? Leptin is going to activate the hypothalamic pituitary axis as well as the gonadal axis, and causing a pulsatile GnRH release. The pulsatile GnRH release is going to cause central activation of puberty. And that central activation of puberty is then going to also increase LH and FSH. And remember that LH and FSH are also going to stimulate the ovary, which is also going to stimulate the ovary to cause estrogen production and the peripheral conversion of thyroid. So they'll get the breast development and the uterine changes and maturation of the ovaries. So it's kind of like a cycle there. Also, the central activation of puberty by pulsatile GnRH release can cause adrenarche, like we said, accelerated bone growth, and advanced bone age. And you need to know that Blacks and Hispanics and obese children of all ethnicities are the most prone to prematurity. So testosterone is going to be secreted normally by descended testes. Undescended testes are going to cause adrenarche. Often, it's not going to cause adrenarche. It's going to result in adrenarche being delayed, as abdominal and inguinal testes are going to be dysfunctional. You need functioning testes to produce adrenarche, which was the body odor, oily hair, skin, acne, pubic hair, and so on. All patients with central precocious puberty should receive a CT or MRI, and you want to treat with GnRH analogs. Okay, so the next topic here is central venous peripheral precocious puberty. So you can have secondary sexual development in girls or in boys, Girls are going to be less than 8 years old, and boys are going to be less than 9 years old. So secondary sexual development in girls and boys are then going to be measured by bone age. Bone age is then going to be either advanced or normal. Normal bone age will cause isolated breast development and premature thalarch. So you need ultrasound and reassurance at that point. And normal bone age is also going to result in isolated pubic hair, premature adrenarche, which also you would have ultrasound and do an ultrasound and then reassurance. Bone age can be also advanced. Advanced bone age, you'd want to check a basal LH level. So at that point, you want to know if the LH is going to be low or high. If it's low, you want to do a GnRH stimulation test to see if you can get that gonadotropic releasing hormone to stimulate LH production. If the LH production does not occur, so you still remain with low LH, then you have a gonadotropin independent peripheral precocious puberty. So if the patient has peripheral precocious puberty, but their LH levels are low, even with a GnRH stimulation test, that's an independent gonadotropin problem. Versus if you do the GnRH stimulation test and that low LH suddenly is now high, then you have a gonadotropin dependent precocious puberty, or also called central precocious puberty. And that also goes all the way back when you check the basal LH with the advanced bone age. If you immediately off the bat get high levels of LH, then you immediately have a gonadotropin dependent central precocious puberty. If you do have a central precocious puberty, you want to check a brain MRI, and you want to do that with a contrast. The brain MRI is going to either give you the results of something of it being either idiopathic, or there can be an intracranial mass. If you do see an intracranial mass on a brain MRI with high levels of LH or central precocious puberty, then you want to surgically resect that mass. That would be the most definitive step. If you do an MRI with contrast and it's idiopathic, then you want to treat with GnRH agonists to prevent premature epiphyseal plate fusion and to maximize adult height potential. So girls less than 6 years old can grow 10 centimeters, and 6 to 8 years olds can grow between 4 to 7 centimeters a year. So remember that central precocious puberty, 80% of cases are going to be idiopathic, and that hypothalamic or pituitary tumors are going to account for more cases in boys, but it must be ruled out in girls. All right. Then you have something called constitutional growth delay. So for constitutional growth delay, this is the most common cause of short stature and pubertal delay in adolescence. They can have a normal birth height and weight, and they could be between the ages of 6 months to 3 years. The height and the growth velocity are going to slow, and the child is going to drop the percentiles on the growth velocity curve. At 3 years old, there could be a normal gain of growth velocity, and that growth velocity can follow at the 5th to 10th percentiles. And then puberty and adolescent growth spurts are going to be delayed, but eventually they are reached. So it's normal to be a little bit delayed, because eventually it'll be fine. It'll reach its normal point. Bone age radiograph, that's going to show a bone age that is delayed compared to chronological age. So you have your typical growth chart that starts off at 2 years old on the x-axis, and stature and weight on the y-axis. And as the patient grows older, 2, 3, 4 years, the lines are going up. And in constitutional delay, growth delay, the lines start off somewhat normal, but then are always just below the normal growth curve. But eventually, it should come back to normal levels at puberty. And that's the end for pediatrics endocrinology. Next would be endocrinology for OB-GYN. So the thyroid gland and OB-GYN, you have maternal thyroid accesses during pregnancy. So here the hormones, the T4, the free T4 and the TSH are going to have a change during pregnancy. The total T4 is going to increase by 2. So 2 times the increase of total T4. And the free T4 is also going to increase. And the mechanism behind this is that beta HCG is going to stimulate the thyroid hormone production. So when you're pregnant, you have beta HCG, and the beta HCG is going to stimulate thyroid hormone production. And there's also thyroid bindingglobulin is going to be increased, and that binds up all the extra T4, and it results in a significant increase in total T4 and a slight increase in free T4. So remember that free T4 and total T4 are both going to increase during pregnancy. And TSH is going to decrease because the increase in beta HCG and the increase in T4 in the first trimester are going to suppress that TSH secretion. So in patients with hypothyroidism, levothyroxine should be increased in pregnancy by 30% at a time because of that TBG. Pregnancy is detected and should be adjusted subsequently, typically in 4-week increments, and that's based on the TSH using pregnancy-specific norms. The T4 should also be monitored using pregnancy-specific norms. Adverse effects of hypothyroidism on the mother and the fetus would be like gestational hypertension, preeclampsia, and premature delivery and postpartum hemorrhages. We went over this more detail in the gynecology, obstetrics and gynecology lecture. So if you would like to refer to that as well, this is just a very quick review of that. Then you have genetic testing. So in women have a high risk of aneuploidies. So previous fetal aneuploidies or abnormal ultrasounds and aneuploidy screenings with ages greater than 35 or a history of balanced Robertsonian translocations are going to require further genetic testing. Cell-free fetal DNA is going to be your highly sensitive and specific maternal blood test that can detect trisomy 13, trisomy 18, and trisomy 21. Then you have your gestational diabetes in pregnancy, and there's a 2-step approach for screening and the diagnosing of gestational diabetes. So at 24 to 28 weeks gestation, the first step is to do the 50-gram oral glucose load and check that serum glucose an hour later. If the blood glucose is less than 140, then it's unlikely the patient has gestational diabetes and no further testing is required. But however, if the blood glucose levels are greater than 140 after that 50-gram oral glucose load, you want to go on and do step 2, which is administer a 100-gram oral glucose load and check their fasting serum glucose levels each hour afterwards for up to 3 hours. And the diagnosis of gestational diabetes is going to be more than 2 of the following. So your blood glucose levels, if it's fasting, should be more than 95 or more than 105. These are due to different values, different criteria. So the NDDR would be your National Diabetes Group criteria. Then you have your Carpenter's criteria and Coustan's criteria. But you get the idea. So fasting would be more than 95. And 1 hour it should be more than 180. At 2 hours, more than 155. Or 3 hours, more than 140 will give you the diagnosis of gestational diabetes. And you need 2 of those values to be abnormal. Then you have your gestational diabetes target blood glucose levels. So fasting should be less than 95. At 1 hour postprandial, it should be less than 140, and at 2 hours postprandial, it should be less than 120. And then treatment, first-line treatment for gestational diabetes would be dietary modifications, something very simple. Second-line treatment, meaning that dietary modifications didn't work, would be insulin and oral agents like metformin and glyburide. There's an increased prevalence because of obesity and obesity is an epidemic in the US, there's an increased risk in gestational diabetic patients of if they have gestational hypertension. So gestational diabetes can cause gestational hypertension, can cause preeclampsia, and can result in a cesarean delivery. The outcome typically resolves after the delivery, but 50% of women often progress to develop diabetes type 2 later on in life. So how do you screen? All pregnant women should be screened between 24 to 28 weeks of gestation, and patients with increased risk factors like a high BMI of greater than 30 or a previous diagnosis of gestational diabetes in a previous pregnancy, and excessive weight gain during pregnancy, a family history of diabetes, Hispanics, African Americans, and Native Americans, or symptomatic patients that have polyuria, polydipsia. These should all be screened at the first prenatal visit with a hemoglobin A1C and a fasting blood glucose, as well as they need to be rescreened between 24 to 28 weeks if the initial screen was negative. So in these patients with those risk factors, they should be screened earlier on, and then subsequently they should be screened again between 24 to 28 weeks. And then finally, we have fetal and neonatal complications from maternal diabetes mellitus. So what are some of the fetal and neonatal complications that maternal diabetes mellitus can give you? If the mother has maternal hyperglycemia within the first trimester, congenital abnormalities can happen, such as congenital heart diseases, neural tube defects, and a small left colon syndrome, as well as they have increased risk for spontaneous abortion if there's hyperglycemia within the first trimester. If there's hyperglycemia between the second and third trimester, then you have a risk of fetal hyperglycemia, and fetal hyperinsulinemia can result because of the hyperglycemia. And then if the fetus has hyperinsulinemia, they're at risk for metabolic demand, an increase in metabolic demand, which will then give the fetus hypoxemia, and that hypoxemia causes an increase in erythropoiesis, and the fetus will have polycythemia with hematocrit levels of greater than 65%. Other complications of fetal hyperinsulinemia would be like organomegaly, like heart and liver organomegaly, so those organs will be very large. Fetal insulinemia would also cause macrosomic babies, and they're at risk for shoulder dystocia and birth injuries like brachial plexopathies, clavicle fractures, and perinatal asphyxias. And then finally, fetal hyperinsulinemia can cause a neonatal hypoglycemia. Because of the fetal hyperinsulinemia, the fetus is in constant anabolism, and that causes an increase in metabolic demand, and that high metabolic demand causes hypoxemia. Then that hypoxemia is going to result with polycythemia or an increase in erythropoiesis, and that's dangerous because it causes a very thick viscous blood, which can give you a risk of sludging and ischemia and infarction of the vital organs. Newborns are going to be required to be closely monitored with CBC monitoring and signs of perfusion. Hypocalcemia is typical in infants of diabetic mothers, and that's due to the parathyroid hormone suppression. Neonates are usually asymptomatic, but they should be monitored for hypocalcemic seizures. So remember hypocalcemia with hyperglycemia in fetuses. Also, small left colon syndrome. Infants of pregestational and gestational diabetic mothers are going to be at increased risk for small left colon syndrome, which causes a transient inability to pass meconium. This resolves spontaneously, though, and it's not related to intussusception. And that is the end of pediatric endocrinology.